you guys first time in this room? Oh, it's a little more crampy, but these third years have priority. Thank you for moving in here.
I like this room.
But
It's cozier. It's like we're all together.
it's really warm with everyone in.
Because you're right.
Okay, we are very happy to be here this morning to talk to you folks about both a little bit about caring for the underserved and then also more specifically your introduction to home project, which you will all be rotating through. And we're going to kind of explore like better ways maybe to approach patients in this population too. Okay. All right. So before we begin, if you can log in to everywhere. And just kind of throw out who you think the underserved are. Let's see. And obviously, there's not like one right answer. There's I see a lot of good things up there. You guys can keep putting it in. I'm just gonna, yeah, very nice, very nice. Then the next, sorry. Okay, so yeah. So individuals that are vulnerable certainly are underserved. There's a little bit of a difference though between vulnerable and underserved. So the people that we consider more vulnerable, right? They have kind of there's something about the individual themselves and their situation that puts them at increased risk, right? For diseases or poor outcomes and things like that, right? So all of these individual categories of people would be considered vulnerable, more vulnerable than the general population. I think that one thing I would like to point out that oftentimes gets overlooked in the vulnerable category is individuals living with disability. And I'm talking to the third years today about individuals living with disabilities. So that's why I was kind of extra thinking about that. But they are a very vulnerable population that is underserved, and we should try to remember that. So when we talk about vulnerable versus underserved, there certainly is an overlap, right? But again, so vulnerable populations, it's something about who they are that puts them at this increased risk, whereas underserved populations have fewer, access issue, right? So they have fewer resources, and for one reason or another, they can't access the same resources as the general population. And so there certainly is this overlap, but there's a little bit of a difference. So we like to talk about the difference between equality versus equity, right? And so, there are people who feel like, everything should be equal, right? Where we should be an equal society, but they're, when they're talking about equal, it's more like this picture then, right? If everybody gets the same thing, there's still a lot of inequity, right? Versus to make the outcomes equal, right? You can't provide the equal amount of resources and other things, right? Because in order for everybody to be able to see the baseball game, it has to be different depending on where they are starting from, right? And then, we like this picture too, because this is oftentimes the reality of it though, right? Those that need things the most actually are put at even more of a disadvantage because of the way that policies are and things like that, versus the ones that really don't need it are given the most help, right? And if you look at how your tax dollars are spent, right? If you look at the true benefit of tax dollars, like the upper echelon of the SES receives much, much, much more benefits, right, than the lower part. So it's kind of crazy, but. And then a few years ago, we were visited by Dr. Okamami. If you haven't heard of him, I would recommend that you look him up. And he's an amazing individual who is a strong advocate for disability. He became paralyzed in his internship year. He was an orthopedic resident, and then he got into a bad accident and became paralyzed. But went on to he's not an orthopedic surgeon, but he actually still does surgery in this like super cool stand-up wheelchair thing. But he's actually a family physician. That's not why he's cool, but it is one of the cool things about him. But he had this slide, which I really like, because sometimes it's not, even if this was a tall box, right? That's still not equitable for this individual, right? So it looks different for different populations. And he also had this slide, which I really, really like, because really we shouldn't need the boxes at all, right? And there should just be no fence. There should be no barriers to everybody being able to see, right? So that's how we should think about it. And so it's kind of like this example, right, between inequality and then equality, providing the same ladder but still not equal, right? Versus equity, which is good, right, because they can both reach the apples, but really justice is fixing the problem, like upstream, right? So balancing out this tree, providing support so that they can both get what they need. Okay, I'm going to hand it off to Dr. Schiff-Elfalan. Thank you.
All right. So in this portion, we're going to build upon things we've already been talking about. So we introduced the idea of trauma. We've thought a little bit about trauma-informed care, moving from what's wrong with you to what happened to you. We've started to think a little bit about ourselves and the thoughts that come quickly to our mind that may influence the ways we interact with someone or how we ask questions. And so today we're going to use a lot of that and continue to build on it with skills for how can we apply those concepts to taking care of people. So here are some of the objectives for this portion. We're going to kind of understand trauma-informed care, define it in its relevance to medically underserved settings, and its relationship to social drivers of health. And one question I was have you already covered social determinants or social drivers of health? Yes? Okay, great. Perfect. So we'll just reference them in this talk. We'll think a little bit about behaviors and communication patterns that can either promote safety or risk re-traumatizing people and what we can do instead. And then we'll also, in the same practice, reframe our encounters through a healing-centered strengths-based lens. So the first thing, as we start this portion, I want us to start by noticing ourselves. So I'll ask you to put your both feet on the floor. And all we're going to do is take one slow, steady breath in and out. Being grounded can help us to be more present. And so if we find ourselves wandering, we feel ourselves starting to escalate, if we're in clinic or we're in class or whatever is going on, we're starting to feel like, hey, I'm starting to get a little nervous or I'm starting to feel overwhelmed. This really simple thing of just like stopping what you're doing, putting both feet on the ground and taking a deep breath in can help us come back to that moment. And it's I'm sure you do this all the time, but such an easy thing that you can use anytime, right? And when you have a chance, I'd say an even better is if you have a chance to go outside and put your feet on the grass, take off your shoes or your slippers and stand there, take even just one breath and feel the sun on your face, even more so can that help you to come back to center. So hold on to that. We're going to come back to that later. All right. My formatting got.
Oh, I'm sorry.
Oh, that's okay. It's okay. Let me see what I wrote there. So I was just revisiting a definition that we had seen before. So I'll read it off of my slide. This comes from the Substance Abuse and Mental Health Services Administration. Individual trauma results from an event, series of events, or a set of circumstances that's experienced by an individual. It can be physically, emotionally harmful or life-threatening and leads to adverse effects. Remember hearing this definition? And that those long-lasting effects can be anything emotional, spiritual, physical, any kind of well-being. And I really like this summary statement by Dr. Gabor Mate. Some of you may have heard of him before. He wrote a very popular book a few years ago called The Myth of Normal. He's also a substance abuse physician and family medicine doctor. But I really like his summary. He says, trauma is not what happens to you, it's what happens inside of you as a result of what happened to you. And so that same organization that gave us this definition, which is just one definition, they also gave us some tools for thinking about this. And we'll revisit this again, actually, as you move further into your training with even more principles. But first, they say the 4 R's of the trauma-informed approach are to realize, recognize, respond, and resist. And so realize, we've already been doing that part. Like we talked about, trauma is so ubiquitous. It's better for us to assume that someone has experienced some kind of trauma than to assume the other. And so by just always wondering what might be going on in someone's life, that can help us to reframe always, right? So realize many people are affected by different kinds of trauma. Recognizing signs and symptoms. So when we start to notice when people are acting withdrawn, or they're starting to get angry, or they were totally fine one moment and suddenly they're like lashing out or acting scattered, or something has changed, right? And sometimes it's really subtle, and sometimes it's big, and we don't always link it back to trauma, but if we use a sense of wondering, I wonder what might have happened in this moment to have this person act that way. You can ask that about yourself too if you start to feel some kind of way you weren't expecting. I wonder what might have happened just now that made me start to feel nauseous, angry, uncomfortable, whatever those things are. Respond is how can we use effective methods of care? We'll spend a lot of time on that part today. and then resist. What are the things that we can do to try to resist re-traumatizing? So that kind of preventative aspects. Okay.
Oh my God, I'm so sorry.
I'm sorry. We merged slides and I lost my sorry. All right, I'm gonna switch back to the here. It's not working. Okay, I don't know. It says I entered the wrong password, but I. Oh. It's okay. I'll just go back to yours. Just imagine that my animations were
Oh, here, why don't you just
correct.
do it?
Okay. Okay, so I wanted to share this short video from the American Academy of Pediatrics. This is Dr. Dina Hubbard talking about how practicing in trauma-informed care has really transformed the way that she has worked with patients as a neonatologist. I thought her story was really compelling, so just listen. And while you're listening to her story, think about how she went through these 4 R's herself as she was thinking about interacting with this family.
Things through the lens of trauma-informed care, it's like a superpower, and you can't unsee it. This mother had previous babies in our NICU, so she had a bit of a reputation. How she responded to the team and how she acted was outside of kind of the norm. And so I thought, I am going to set boundaries for this mother, how she interacts with our team. By the time that we were able to meet, this very premature baby needed a surgery for a shunt in his brain. And I started out by asking her, do you know anyone who's had a shunt in their brain? Much to my surprise, her answer was, yes, my mom had a shunt in her brain. She was shot in the head when she was pregnant with me. Wow, I was not expecting that. And then she went on to tell me some other traumas, being a victim of intimate partner violence, the father of this baby being murdered just 2 months prior to his birth. I thought, oh my goodness, I judged this woman that I was taking care of her baby. I recognized that I was judging instead of being curious, and it has really changed, again, how I see things. And so I mentioned the lens of trauma-informed care, and it's like putting on glasses that are a superpower. With that great power comes great responsibility.
All right, so I hope, most of the stories may not be that dramatic, but I think the main message is just this wondering, like, what else could be there before we jump to make judgments about why someone may be showing up the way that they are. Okay, and so since you already have talked about social determinants, that's great. So these are the conditions where people work, live, and play, and these are those upstream effects that affect what we see in our clinics and hospitals, right? And for people, and so part of the change from social determinants to social drivers is that they don't necessarily have to determine what happens to you. However, they tend to drive a lot of those outcomes, and they can be positive or negative, right? You can have positive drivers that push you more towards better health, and negative drivers that push you more towards poorer health. And those can, in and of itself, be part of that trauma story, depending on what kinds of access issues people have had, what kind of discrimination they've experienced, and what kind of struggles they've had in their life to that point. And so we've already heard a little bit about medically underserved communities, and most of our country is underserved. Most of our world is underserved in terms of medicine. And part of those things can be either structural. I saw a lot of the things you all put up may be related to access, may be related to insurance. So those are more structural factors. They could be personal factors. If you feel like this is a system that doesn't understand you, doesn't know you, doesn't see you, doesn't speak your language, both language, the words that we use, English, Spanish, Mandarin, whatever the language is, or doesn't speak my language, wow, these are people from a completely different life experience that doesn't know how to interact with me in a way that feels authentic or makes sense to me. And those may be reasons why they don't seek care. We end up seeing a lot of people at the home clinic who are insured, but they come to see us because they felt like when they go into regular clinics, people don't necessarily treat them with the same kind of humanity that they come to have at the home project, and which we hope they would have everywhere. And so, as we talked about before, if there's something that feels kind of just not quite right, trauma is often that elephant in the room. And so for all of you, as you start to go into clinics, you're going to be doing a lot of observing. And so if you start to notice these shifts in the energy in the room, you might pick something up that others didn't. And so ask your team, check in with the patients, maybe when they're sitting off by themselves and quiet. And we'll come back to some of those, like what can I actually do and say. We don't expect that you are going to be doing any screening yet. This will come later, but I included this just so you have an idea of, like, when we screen for stress and trauma, it doesn't need to be any major questionnaires or opening up some big thing of like, have you ever experienced, in the case of Dr. Hubbard's story, have you ever experienced someone being shot or killed? Or we can start by just asking, like, are you experiencing any stressors that may be affecting your health? So sometimes we're not aware of how the stress may affect whatever it is that they come in for. So I'm just asking because I want to take better care of you. So kind of opening up that opportunity for them to say, well, I didn't even think it was related, but this is going on in my life too. Okay, so we're gonna do a couple of vignettes just to work through what would it look like or feel like with a couple of different patients. So this first one, a 42-year-old patient with chronic wounds and skin infections has missed 3 follow-up appointments. Today they arrive without any of their medications, their bandages are dirty, and they seem withdrawn. So maybe the first question, what is a common reaction you would expect if this person showed up at any clinic or hospital? What is kind of the initial reaction that is most common, or initial thing somebody might say? What happened? And what happened in what way? What are they asking about?
Why did you miss your appointments?
Yeah, where have you been? Why'd you miss your appointments? Great. What else? What's the student or clinician wondering about?
how their bandages got dirty.
Yeah, what's been going on? How'd your bandages get dirty? Where have you been? What's going on? In this moment, so this person's been away for whatever reason, and they're here today. So what kinds of behaviors or words do you think could promote trust and open up the conversation?
You're asking them how they're doing.
How are you doing? Yeah, like really genuinely, how are you? What's going on? What else?
You could say you're happy to see them.
Yes, thank you. I think that little shift is such a huge game changer from where you been, what's like, how come you missed your appointments, to I'm so glad you're here. Let's see how I can help you today. What's been going on? How are you? Yeah, beautiful. What kinds of things might risk re-traumatization if there's a reason why this person, well, let's talk through a couple of different potential things. Let's say this patient has experienced some kind of trauma. What kind of trauma do you think might have prevented him or her from coming into clinic today or these last days?
You like judgment from healthcare providers?
Yeah, so maybe they've experienced some kind of stigma. Their last experiences with the clinic was negative. What else?
Lack of transportation to get there.
So they're experiencing some kind of access issue. Maybe they didn't have transportation. Yeah. What else?
Blaming them.
What's that?
Blaming them.
Blaming them, so they're feeling maybe some shame around not coming in.
With houselessness, maybe they their area got swept and they had to relocate.
Yeah, so maybe there's some kind of social issues going on, or so they physically were unable to come in or had other things they needed to deal with at that time. Yeah, great. It could be any kinds of. So I'm so grateful for the suggestions, because what we heard is it could be some things that they're feeling internally. It could be some things that we did, the general medical, it could be us personally, or it could be we, the general medical institution, or it could be things like outside of how they're feeling or us, like their experience. Maybe they're having intimate partner violence. Maybe somebody in their family just got injured or sick, or they had to take care of someone else, right? Maybe there are other things they had to take care of as a priority, or access issues, etc. So what might risk re-traumatization in this encounter? We don't need to know what the trauma is, but for whatever reason, they didn't come in. And so what may make them less likely to come back?
If you scold them or make them feel bad.
Yeah. If we scold them or make them feel bad, and sometimes these are really subtle. I don't know. I was just speaking for myself, but there have been all kinds of times when my parents have told me something that they did not intend to be scolding or judging me, but I interpreted it that way. So again, kind of thinking about did something shift in the body language or energy when we say something, and then we can wonder oh, might I have said something? But yes, definitely overt scolding or blaming can re-traumatize. What else? But yeah, making fun of our patients, even if we think we're just kind of joking and trying to be friendly, jokes can come off as really harmful depending on who is receiving that joke and what they've experienced before. Yeah, great, thank you. And so any other, just this question is just for our own reframing in our mind. So certainly, let's paint the picture a little bit more about us. It's the end of a day. It's been a really rough clinic. It was chaotic. We're tired. We're trying to go home. People were yelling at us. And now this person comes in. It's the end of the day. It's already been 3 visits where they haven't come, and now We have to figure out why their bandages are dirty and get them to talk to us. In our minds, we may be having all kinds of negative narratives even before we've interacted with the person at all. Is there something, and there are lots of different ways that we can reframe this, but just can anyone give us an example of how we might reframe the story in a strengths-based way, hearing all the possible things they might have been experiencing, so that we can maybe change our thinking before we go in to talk to them? Any ideas?
Despite whatever's going on, they made it a priority.
Yes, thank you. Despite whatever is going on, they made it a priority to be here to see us today. So let's see what we can do to help them. Thank you so much. And we heard so many of these already. That's beautiful. And so thank you. Okay, we'll go through this one quickly. 58-year-old patient experiencing houselessness comes in for a wound check. When the medical student introduces themselves, the patient says, "I don't want to talk to another person. You're all the same. You don't care about me." This happens sometimes at our clinic too, where the patient will either say, "I don't want to talk to another student. I only want to talk to the doctor," or "I don't want to talk to another person. I've had to talk to so many of you already. Why do I just give me some medicine and let me leave?" And so this part of the question, I'm wondering what kinds of feelings that might bring up for us when that happens. If you're here to learn, maybe you come in, you're enthusiastic, you're excited, you're caring. And then this person, before they've even gotten a chance to get to have one word with you, they say, "I don't want to talk to you. Don't look at me." How might that make you feel? We don't need to say it out loud, but how might that make you feel? And when we think about then how could we respond, recognizing something else might be going on with that patient? Likely something else is going on with that patient that has nothing to do with you. So any suggestions for how you could respond without taking it personally?
You could acknowledge the process is like you have to talk to a lot of different people when you go to the home clinic to check in, like the volunteers and the med students and then the attending. So it is like a process. So I guess just acknowledging that, yeah, they do have to talk to a lot of people and like that you're just, doing your part in it to try and get them the care they need.
Yeah. I think acknowledging processes and acknowledging feelings can go a long way. So I'm learning how to be a parent. Every day is a new adventure. And I have a 4-year-old, and I found through my parent teaching lessons, acknowledging feelings can go a long way. Like when he's having some big feelings, big emotions, and I say to him, "Wow, it seems like you're feeling frustrated," or "It seems like you were sad when I said no earlier. Are you sad?" I wouldn't talk. You don't necessarily need to talk that way with your patient, but the same idea, right? Like acknowledging the feeling, acknowledging, as Lisa was saying, this is a really long process. I understand if you're feeling frustrated. I want to help you move through the process as quickly as possible. Is it okay if I can collect that information to move us forward? So acknowledging what they may be feeling and how you might be able to help with that. I think that's a really helpful part, is like responding about what's going on rather than responding to your feeling. And in a similar way, that language can reduce power imbalance, like asking for permission and giving power back to that person. And so it sounds like you've had some tough experiences. Thank you for sharing that with me. Would it be okay if I asked what's been most frustrating about that? Maybe they don't want to talk about that. Maybe I just want to move through this. I'm trying to catch my bus so I can go and pick up my social security card, whatever the things are, right? And so again, going back to that same idea, being curious can be really helpful. And so similar to what we heard in the last vignette, instead of this patient is angry and resistant, but rather this patient's experienced a lot, but they're still here showing up for care. So how can I help them move through this? And what you do in that moment can really have an effect on what happens the next time. All right. So this next part is kind of just building upon that. So in those moments when you're having some kind of challenging situation, the first thing we should do is to pause. And that's part of why we started with the breath. However you like to take your pauses, if we can't always exit the room, but sometimes that's necessary. But if you're staying in that moment, what are the things that are helpful to you to help you pause and regulate how you're feeling? Why trauma-informed care often starts with our own nervous systems. Our patients and the people around us are noticing our tone, our feeling, our pace, our energy. And so here's just some suggestions of what you could do. Take a slow, deep breath before you enter the room. If you're noticing your body, you might notice that you're starting to clench up or your jaw is clenched, so softening your body can help you to calm down. Planting your feet on the ground, reminding yourself, I don't need to fix everything. Sometimes we just need to listen. Kind of going back to that Brené Brown empathy video we heard, a lot of times people just want to know that we care and that we're listening to them. And then if you're overwhelmed in the middle, you could briefly pause and say, let me take a moment to make sure I understand. And then you reflect back what you're hearing so that they can correct you and say, that's not at all what I was trying to say, or yes, thank you, you're really hearing me. The next is permission. So asking always before we do any kind of sensitive questions or exams. And we don't always know what's going to be sensitive. I was really surprised. I had a patient at home clinic who came in with concern for lice, and she was wearing a head covering. And so naturally we thought that she's here for, she thinks it's lice, and so naturally she's going to want us to examine her head and then be able to treat her. And she was so upset when we started that part of the physical exam. And you know, after we took some time to pause, reset, ask more permission, ask clarifying questions, she had such sensitivity over her scalp that she was afraid for us to touch. She was embarrassed for us to look. And so I would not have thought a scalp exam is a sensitive exam. And it just kind of highlighted for me that we just never know. And so asking permission for anything can help our patients to feel like they have power back. So here's some suggestions. Would it be okay if I ask you a few questions about your living situation? It helps me to understand your health better. Some of these questions may feel personal. Is it all right if I ask them now? They may say no, like we're not really in private. I don't really feel comfortable answering that right now. I'd like to examine your shoulder. How does that sound? Is now a good time to talk about your mood, or is there something else you'd like to discuss first? So asking for permission can be really helpful. And then this last part is presence. So 3 Ps. This part, presence. When patients are sharing, listen with your full attention because they notice when we are distracted or rushed. And this can be one of the most challenging parts because we often are distracted and rushed. Right? We may have other patients waiting for us. We may have other team members waiting for us. We have to be at another clinic in a couple of hours, whatever the things are. But definitely if your patient is sharing something sensitive with you, stop what you're doing, put your things down. We're not taking notes, we're not looking at our laptop, we're just sitting there with that person and hearing their story. If it becomes a point where you need to take notes, then is it okay if I take some notes while we talk so that I can help you with these things afterwards? Yeah. Allowing space for silence can be really powerful. Sometimes we just need to sit there together with what may feel like a really long time, but probably is like 30 seconds, maybe a minute. Your patients will then fill that space with what they need to say. And whenever we can, sharing our appreciation. I appreciate you sharing that with me. Thank you for coming in. I'm so glad to see you. Those sorts of things can be really helpful. Okay, so we're gonna practice just for a few minutes. Just turn to some people near you, and one will be the medical student, one will be the patient, and the other is observing. And so the first person will just be look upset when you ask about their living situation. The second one, you need to ask about substance use, but that person is the patient's crossing their arm and not looking at you. And then the third one is you want to do a physical exam, and the patient seems to feel tense. And really the purpose of this is for you to run through, as the medical student, how will you pause when encounters get difficult? How will you ask permission? And how will you demonstrate presence? This should only take 1 or 2 minutes for each of you to go through. It is likely going to feel awkward. It may feel clunky. You might not have the right words. That's okay. But these are not going to come naturally to you unless you practice them. So this is our first practice. So I'll call a minute and a half, and you can switch. So get into groups of 3. Pick a person A and go ahead, get started. Thank you. Thanks, everyone. If you can hear me, clap twice. Thank you. All right. Anyone want to share something that a partner said that was really, really helpful in kind of whatever practice, either pausing or permission or presence? That we're like, oh, I want to use that when I'm.
I don't know if it was one of the three, but I really like this one. For scenario C, said, okay, instead of doing like a physical exam first, let's start with a visual exam, and we can talk through it. And if there's any specific areas I think we need a physical exam, we can get to it when we get there.
That's great. I think that's kind of like, it's kind of like asking permission, where you're like scaffolding before we get to touch. Is it okay if I look? Yeah, wonderful. Thank you. Anyone else have something that they thought was really, really great? That they might want to use too.
Sarah here was really great at like internalizing that locus of control, where like letting the patient know that they don't have to share anything they're not comfortable sharing, do anything during the exams they're not comfortable doing, letting us know if there's any boundaries that are being crossed, etc.
Wonderful. So like really giving that patient back that control. We can stop anytime. You don't have to answer any questions you don't want to. Wonderful. Thank you. Maybe one more.
Angel reminded me of this, and Maddie did this really well, like providing an explanation for why we need that information. Like that, yeah, gives the patient way more information on like why we're asking these uncomfortable questions, or why we have to do something to them that they would be uncomfortable with.
It's beautiful. Context really matters, right? Like, why do you need to ask me about all of my sexual partners when I came in for a cold today or something, right? That can be really, really helpful. And then you don't need to answer these questions if you don't want to. Here's why I'm asking. Wonderful. Thank you so much. And I'm sure there were lots and lots of other great things that came up. And so keep practicing, keep sharing with each other, and watch each other. Watch your teachers and one another. There are going to be lots of things that you really like and you want to take, and other things where you're like, oh, I really don't want to do that. Remember those as well, and don't do those. So the last activity we'll do in this section is practicing changing some of the words, which basically this is just bringing it all together. We've already practiced a number of these. And so on the next slide, we're going to see some commonly used phrases that we either hear or see written in a note. And so what I'll ask you all to do is take a few minutes to rewrite them. And we're going to share them on the same document so that we can all see what you come up with. So what I'm gonna add, we already did number one actually. Why didn't you come in sooner? Instead can be, I'm so glad that you're here. Before you write on this document, what I'm gonna ask you all to do is go back to your groups of 3 and come up with your answers first so that you don't get influenced by what other people are writing down, and then you'll add them to the document, okay? And that document, then you all can have it and see what other things people come up with. So in this side of the room, let's do numbers 2, 3, 4 from here. If you're in the 3, stay with your 3. If you're in the middle part of the room, do 4, 5, 6. Wait, sorry, 2, 3, 4, 5, 6, 7. 5, 6, 7 in the middle, and then 8, 9, 10 on this side. Okay? So I'll give you a few minutes to come up with the rewrite. The one your group has it, then go ahead and just add it to the document. You can see what others are writing too. Okay, any questions? Okay, thank you.
Patient is experiencing difficulties adhering to hard climbing. You guys are so nice.
No, I like that short
If you drop all these instructions,
Please follow.
Oh my gosh, right? That's so
have 1 more minute.
I thought you also did
So like, take the words out of them.
Oh no, I
It's Japanese here.
Thank you all so much. I hope that what you're seeing here, I know this is in some ways an orientation to home clinic, which we'll get to shortly. But this is just like practices we can use in any clinic, in any setting. Right? How can we reframe both to be trauma informed, which is really like a awareness of potential harms that have come, and healing centered, which Dr. Sean Jinwright talked about. Is healing centered engagement takes us not only from recognizing what harm exists, but how can we reframe and think about how can we get to healing and trust and promoting that empowerment. So we won't go through all of this together now, but we're going to post this to your drive. And you can take a look at the suggestions and kind of crowdsourcing different ways that you can say different things. So like you need to take better care of yourself. I think this comes up a lot, especially when people come in, maybe their blood pressure is not as well controlled as you had talked about, or they said they were going to start going to the gym and they haven't, and they've already had multiple heart attacks and all. Like it would be easy to say you really need to take better care of yourself. But and even when coming from a good place in our hearts, can come off as shaming or blaming, right? And instead, so we see what changes can we make so that you can feel your best. I care about your health and I don't want you to get sick. So what are some things you can do to take care of yourself? And asking that, putting that control back on the patient. What is realistic for you? What can you do? What can you do? What do you want to do? Is there anything going on that's getting in the way of you living your healthiest or happiest life? How can we work together so that partnership, beautiful, to make your health a priority? I want to get to know more about you to better personalize your care. Do you have good access to whatever that thing might be? So these are beautiful, and so I'm looking forward to. I'll read through the rest. I hope you all read through the rest as well. And so perhaps here, just in this reflection, if there might have been a phrase that you reworked that maybe felt especially empowering when you said it to each other or heard it out loud, what themes have we noticed across these trauma-informed or healing-centered alternatives? What I heard a lot today is how do we put control back on the patient? How do we make space for curiosity rather than judgment? So really trying to affirm before we correct people, curiosity first, restoring choice, and looking for strengths. And so here's what we covered today in this session. And we'll keep thinking about these as we move into the next portion, talking specifically about Home Project. All right, thank you.
The other deck. Oh. And then I saw I had like a weird deck how like the beginning and I was like, I don't know why.
Okay, so we're gonna talk specifically about home project, and one of the first things that you should learn is what it stands for, because a lot of people don't even know what it stands for, and it is Houseless Outreach and Medical Education, which combines the two missions of Home Project. So it's not just about providing better care for our houseless individuals out there, but it really is about educating you and also just the medical community about the houseless and their healthcare needs. And so it's really a twofold mission that Home Project has. Okay, so we're gonna do another poll here. Oops. Okay. So what is the first word you think of when you think of houselessness? I always love looking at this word cloud. I keep it every year. I label it for class. And I really like some of these. I mean, I like all of the words that you're using, but talking about like whoever put gentrification. Like we don't oftentimes think about that, but that is a huge issue when it comes to being one of the causes. I really like this, that because I think a lot of times we think of all of the negative things, and there are a lot of negative things that go along with houselessness, but we forget sometimes about the strength of these individuals, right? And perseverance. You definitely have to have perseverance to make it out there, right? So I really like that. Yeah. Okay. All right. So if you can rank your current comfort level in working with the houseless. actually. This is much higher and fairly comfortable than we usually see. Yeah. But it's totally, we ask you this at the end of your 4 years as well, and we always hope to see an improvement. I think that one of the reasons why I wanted to start Home Project was because I think that a lot of people have just a natural discomfort. Like it's, I think that everybody wants to help. Right? Everybody wants to give back, everybody wants to help, but it is kind of scary for a lot of people. I mean, there are times when I feel scared maybe about a certain thing. I don't know, have any of you ever seen the movie Patch Adams? Have any of you ever heard of it? You guys should all watch Patch Adams, by the way. You should all watch it. It's like a true story. But I always kind of think about, well, now I can't say what I was going to say because it'll give it away. But anyway, there's something that happens in that movie that sometimes I remember and then it makes me nervous. So that's all I'm saying. You know what I'm talking about, right?
Yeah, but
I don't want to tell them what it is because they're gonna all watch it, right? Yes. Okay. It has Robin Williams in it. He's Patch Adams. We actually, you guys have met Patch Adams, right? Didn't he come down?
Oh, yeah,
He
but I
came
wasn't
once.
here.
Yeah. Oh, yeah, he came to visit us. Okay. But so it's totally normal to have those feelings, right? But we hope that by working with this population more in a very controlled environment will help you to start feeling more comfortable. And maybe then when you get out into practice, you will be one of our alumni that come back and give back to Home Project. Or you give back to another organization that is helping either the houseless or some other type of underserved population, right? Okay, so again, this is our mission, right? Those two areas. By the way, so this is one of our alumni that was giving back. She actually moved back to the continent though, but she became a dermatologist and was volunteering at our clinics. Okay, so just some facts about Hawaii's houseless population. So every year, until this year actually, they did what they call a point in time count. And so across the nation, there's like a community organizes just many people going out into the community on one day and basically counting all of the people that are houseless on that day. And so the island is like, set into different boundaries, and different organizations have different geographic areas that they count, and then they all put it together. And this is done on all the islands, and it is actually done across the country. And any state that is or was collecting certain types of federal funding for like housing it was like required to participate in this count. And so Hawaii obviously was one of those. So this year though, they did not do the point in time count, and there is I guess some question about whether they're going to continue it or not, which I think will very much affect funding. So we're hoping that it gets reinstated. But last year, on that day, in Hawaii, there were 6,389 houseless individuals. Now you may think like, that's a very different number from 12 to 14,000 are houseless at some point. But that's because on one given day, that's the only people, right? But some other people may have been houseless 2 weeks before and then are now housed, right? And then it goes up and down, up and down. It's cyclical for some people, so that's why those two numbers are different. And then a large proportion of that, so 4,494 are on Oahu. So obviously Oahu has the largest population of houseless. And so this is the breakdown of the other islands. And then when you look at ethnic breakdown, so 41% are Native Hawaiian or other Pacific Islanders, so that they make up the largest population of our houseless here. Whereas, on the continent, like African American and whites are much higher in their counts. Let's see. So if you look just at Native Hawaiian, though, it's 27%. So if you parse that out, whereas our general population is 20% Native Hawaiian, right? So there is a larger proportion than what you would expect just looking at the population. 14% are children, which is, it should not be, there should not be no children, right? But I mean, that's kind of a high amount. 5% are youth, so they're like 18 to 24, right? 22% elderly. That's really quite sad, I think. And then 2% unaccompanied minors. This has changed over the last 10 years. It kind of went up and down, and during COVID, we actually saw much better numbers because there was a bigger effort to house people at that time. But part of the motivation was not necessarily a good thing because many people felt that houseless people were spreading COVID more than other people were, which is crazy. Also, the numbers, the prevalence of or incidence of COVID in our houseless population was much lower, actually, than in the general population. And for a significant amount of months, there were no cases of COVID in the houseless. And you know why? Because nobody goes by them. So they didn't catch it from anyone. And they don't go by other people. So I don't know why people were so afraid that the houseless were spreading COVID. But it got them housed because everybody was like, we need to get them off the street because we need to control COVID. Which, okay, whatever, like if that's the reason they're gonna get housed, that's great. But after COVID, then things started to reverse. And so now our unsheltered is quite high. It's 62%, which is not very good. That's the gender breakdown, 23% families, 36% chronically houseless. So chronically houseless is if they've been houseless for more than 2 years. Okay. 11% vets. We oftentimes forget that domestic violence is a large contributor to causing houselessness. So mental illness and substance abuse, I think a lot of times when the lay public thinks about people who are houseless, the first thing that comes to their mind is somebody that's crazy and somebody that's on drugs, right? That is the stereotypical view of somebody that's houseless. And a lot of times that's the people we see, right? That are kind of out there, and we don't, the people that do not have a mental illness don't like run in the middle of the freeway, right? And so those are the people that we see, and that's why people just think about that. But, only 39% mental illness in the houseless, only 31% substance abuse, right? And many times, houselessness itself causes the mental illness and causes them to start using substances. And so it's not the other way around. Sometimes it is the other way around, but many times houselessness is actually the cause of those problems. And then, you'll see, I think that we oftentimes don't think of people with disability as being houseless, but we have many patients that unfortunately have many different types of disabilities that then become houseless, right? So for when we first started Home Project, Hawaii was #1 in the country per capita. And then in the next like 5 or so years, it got better, and we were like 3 or 4, things like that. And then 6 years ago, we dropped down to like 5, which was like super good, you know. But in our last count, we were number 1 again. That is not something you want to be number 1 for, right? So 80.5 per 10,000 people. So the average in the country is 22.7. So Hawaii is really, really horrible. And it has increased significantly in just like 2 to 3 years. So this is the breakdown now. So Washington D.C. is usually not included in when they report out because it's not a state, but it is even though it's high, it's still lower than Hawaii. So New York for the last 5 years was always the top state, but we have surpassed New York now, and then you can see, if you look at just like absolute numbers, then it's California. But that's because California has the largest population, right? So absolute numbers is California and then New York, I think. But per capita, Hawaii is number 1. Now, if you look at just last year, look, we were at 43.4. So actually this data though comes from 2 years ago. So in like 2 years, we've almost doubled the amount of houseless people we have, which is kind of crazy. So this is a heat map of where a lot of our houseless live. And so, you know, like this is in kind of like downtown central Honolulu. Obviously on the west side, we have a large population. And it's actually, so then there's pockets, right? Like Waimanalo and some places on the North Shore as well. And then you can see the trends. So you can see that like with COVID, like our numbers did go down quite a bit, right? And then they have been steadily going back up, which is not good. This is the ethnic breakdown, and these slides are going to be in your drive, so you can look at it later. These are the gender breakdowns between gender, household, race, and age breakdowns between like sheltered versus unsheltered. Okay, so Home Project was started in 2005, and so we just celebrated our 20th anniversary. Yay! Because it makes me feel super old. It makes me feel really old. One of the people that came to the fundraiser was like, oh, Home Project is only 20 years old. I thought it was like 30 or 40 years old. I'm like, how old do you think I am? I was so offended. And he's like, oh, sorry. Okay, so in 2005, I was still a junior faculty. And back then, it was a lot easier to get grants for education. And so I got a HRSA grant to basically start a curriculum in underserved care for JAPSM. So it didn't like give you money to like start a clinic per se, but it did give me time, like it bought out some of my time to work on curriculum, and to like it paid for us to go to like fellowship for underserved care and things like that. And so out of this grant, we changed the PBL cases. So, you know, cases like Jordu were added. So prior to Jordu and some others, there was one case of houselessness, and that case was a schizophrenic veteran. there was one other stereotype. Alcoholic, schizophrenic veteran. And that was the one case that JABSOM had on houselessness. And so very stereotypical, right? Whereas in that, like right around that time, certainly families were the largest population of houseless individuals. And the Pacific Islander Native Hawaiian population were much more prevalent as well, and this patient was a white male that was schizophrenic and a veteran. So we added PBL cases that were more realistic. We added a first-year community health experience. So the home project itself used to be a community health option. And just 2 years ago, we had changed it so that, was it 3 years ago? 3 years ago, we changed it so that all of the first and second years rotate through home. And so we stopped having it as a community health option. And then there was a third-year clerkship experience through family medicine. But when we first started, it was like maybe they would go to home clinic like once or twice throughout their whole clerkship experience. So they did like maybe 2 clinics in their third year. And then there was a 4th year longitudinal rotation. And so now though, all third years still go through home project, but it's a significant part of their clerkship experience. So they go to, if they are on Oahu, they will go to home clinic once a week. And the third years are like the main providers in our clinics. Later, we added HYPE, which is our houseless youth. It doesn't stand for houseless youth, by the way. It's Hawaii Youth Program for Excellence. But we mentor our houseless youth. In that program, we started a leadership elective for former managers. And then, like I mentioned, Home Project became integrated into the curriculum for clinical skills and community health for the first years, and then clinical skills for the second years. So really, how did we start having clinics? Because really, it started off just with curriculum, right? But I knew that I wanted to start a clinic because that was going to be a major part of the curriculum itself. So the first year, so 2005, right, we had our first community health group. There were 4 students in Home Project. And we had nothing. We had nothing at the time. I mean, it was just like, hey, do you want to come join this community health elective? We're going to work on an underserved care curriculum, and we're going to start a clinic, right? And so 4 brave souls joined me, and they were great. They were super great. Unfortunately, none of them are here. Oh no, Jason's here, maybe, but Jason Perga. Yeah. But so we were planning. We were making lots of plans, and then we were going to, at that time, most of the houseless in Honolulu were living at Ala Moana Beach Park. Yes, there are houseless there now, but it was packed. I mean, there were tons and tons and tons of people living in Ala Moana Beach Park. And it was a huge problem, I think, for the city, right? Obviously, tourism is a huge part of our economy and all of that. So in January, the mayor announced that, we're going to have this huge centennial celebration, Honolulu centennial celebration at Ala Moana Beach Park, and it's going to be in May, and it's going to be great. But then, as they were doing this planning, so you guys were just babies probably, but in 2006, Hawaii had biblical rain. So we had 43 straight days of rain in Hawaii, which it doesn't sound like that much, but that's a lot. That's a lot. Okay, so just rain after rain after rain, and these poor people were living out in the park. And so we decided, okay, so we kept putting off having our clinic and are doing our needs assessment because it kept raining. But then we're like, okay, we just have to go out. We just have to go out there and do our needs assessment because it's not going to stop raining. Okay, so we plan to do that. And then literally 3 days before we scheduled our needs assessment survey, they did a major sweep in Ala Moana Beach Park. And because they wanted to get everybody out in preparation for the centennial celebration. And so the reason why we know this part is because at that time, one of our faculty's brothers was on the UH football team. So this is how we know this. But so basically the city, now this is not in any paper or anything like that, but the city hired, or under the table hired, the UH football team to go into the park to get everybody out. Like, no joke. No joke. And because at that time, like, they couldn't send in the police because then that would have looked like harassment, police harassment. So it was still harassment, but the police weren't going to stop them from doing it, right? And so they basically intimidated all of these individuals to get out of the park, okay? And it was a lot of people. It was a lot of people. So, and it was raining, right? Pouring. And so where were they supposed to go, right? So luckily, Kauai Hau Church and Central Union Church both opened their doors, and basically they took half of the people. Well, there was a small portion that decided they were going to just camp out right in front of Honolulu Hale. And, but that, you know, then they got arrested and things like that. But I thought that was pretty cool. Actually, I was going to go, but then my husband was like, no. You're not gonna go. So, yeah, so Central Union and Kauai Hau, I mean, so for a month, they let individuals stay in like their rec center rooms and things like that. It was quite gracious of them. And so we decided, okay, we're just gonna go like to Central Union Church, and we did like pop-up clinics there. And so that's kind of how our first clinic started, was just going to the church. But then, lo and behold, on May 1st, I come to work, and this is the article in the Star Bulletin. It used to be the Star Bulletin back then. And it was talking about how they're going to open a houseless shelter right next to the medical school. Like it was, I mean, and it was, I mean, it's kind of funny that it's called the Next Step Shelter because it was next door to us. So I was like reading this, I'm like, that is right next to us. Like, that's weird. Like, this is a sign, right? Like, we're supposed to be there because it's right next to us. And right after I saw this, we got an email from our facilities director at that time. It was like the worst, like, reactionary email I have ever seen. It was like, lock your doors, everyone. The houseless are moving. They call, you know, people just said homeless. But, you know, like the homeless are moving in next door. So everybody needs to be on guard and lock your doors and be aware of your surroundings. And it was horrible. It was like the most horrible email I have ever seen. And apparently, so we went over that day, me and Dr. Damon Lee and our 4 students and 2 volunteers that we had recruited. And we went over and introduced ourselves, and we're like, hey, you know, you guys want some free medical care? And they're like, of course we want some free medical care. And then they're like, oh, are you guys from JABSA? And then we're like, yeah. And then they're like, oh, because we thought you guys hated us because that guy came over and basically told us that we better watch ourselves. And I was like, what? So, you know, at that time, I was still very, you know, more reserved Asian girl, you know, non-confrontational non-confrontational Asian girl. I mean, I'm still a little non-confrontational, but I'm much more confrontational. But I could not take it because I was like, that is horrible. So I did actually report that to the dean because I was like, this, this cannot be how our students are going to be seeing this situation, right? So but that's how we started going to Next Step. So this is what it looked like at that time. Well, actually, at that time, I think the cancer center wasn't there yet. But so that is us, and this is where Next Step was. Like, we literally could walk to the shelter. And so it was perfect. It was perfect that it was right there. It was like it was meant to be. But we have grown a lot since then. Actually, the Next Step shelter is no longer there. And they have kind of changed over time. But so this is our current clinic. So we went from having one clinic a week. So now we have clinics every day of the week. Many of our clinics are at the Kahua Iwilei Clinic. That's our brick and mortar clinic that we're very fortunate to have, thanks to the city and county of Honolulu. And then we have 3 mobile sites that we go to. We go to Waikiki at St. Augustine's Church. We go to Thomas Square on Sundays. And then twice a month, we go to the Paiolu Kaiaulu shelter out in Waianae. This is our van, in case you've never seen it. It lives in the back of the by the turnabout. We actually have 2 vans. This one is the first van that we got. This is called the Erida. So if you hear us saying like, oh, it's in the Erida, like that's what we're talking about. It's called the Erida, and I'll tell you why it is. But this is where we have all of our we store all of our supplies and our tables and tents and things like that. So this is Erida, who the Erida is named after. So this van was purchased through an anonymous donation in the honor of Erida Reichardt Klemmer. She happened to be the first female chief resident at Queen's, and she became the director of the Hansen's disease program that I'm sure you all learned about, right? And she was instrumental in breaking down barriers for the patients at Kalaupapa and decreasing stigma and allowing more visitation and things like that. And she really was a great advocate for that population. And so I had never heard of her before this donation came in. And I thought that what a wonderful person to have a donation made on the behalf of, and that is very much in line with what Home Project stands for. So in the van, if you ever go in there, there is actually a plaque of her on a horse. So you can read a little bit more about her. If any of you ever worked, or if you scribed at Queen's ER, her son is Dr. Howie Klemmer. He's a ER doc. Yeah. But it wasn't their family that made the donation. It was another. It was supposed to be anonymous, but we actually kind of know who it was. But that donated on her behalf. So yeah. So this is why this van is called the Erida. Just interestingly enough, side note. Do you know what's the most interesting thing about Dr. Klemmer? He's married to the daughter of the former owner of the Broncos. And when they were still owners, he used to be able to get me better tickets. But no longer. That's okay. So this is inside the van. So this is not the Erida, this is the other van. So, it has our the supplies that we use on a regular basis, and it also has an exam table that we can do private exams in. There's a curtain so that, obviously we don't leave the back of the van open when we're doing private exams and things like that. But before, it was very difficult for us to do truly private exams. So this is really nice. There's even a toilet in there. if we need to collect samples and there's no restroom facilities nearby. So it has really been very nice for us to have the 2 vans. So the Arida has all of our supplies in it. It kind of looks like this. Do you notice that it looks organized? This is how it should always look, okay, people? But every time I open this door, I cringe because I'm like, what is it gonna look like? And it's like a mess. So please make sure we keep it nice and organized like this. So this is the Arida, and then the other one, we just call it Sprinter 2. So that one doesn't have a name because it wasn't donated. So the Arida and Sprinter 2, in case you somebody tells you it's in the Arida or it's in the Sprinter 2. Okay, so here are some people that you should know. So Dr. Hernandez is our medical director. Dr. Schiff-Elfalan is our educational director, and that's me. And then Lauren Motes is our administrative coordinator. So she takes care of a lot of our more kind of scheduling, and so you'll probably be interfacing with her for scheduling, things like that. Also some of our finance things. So if you're in HYPE, she handles all of your reimbursements and things like that. She does the scheduling for HYPE as well. And then Hunter is our logistics coordinator. You're gonna get to know Hunter very well. He kind of just does everything, but he knows the clinics inside and out. He kind of is like a clinic manager almost, and he takes care of the day-to-day functioning of the clinics. And then on the end is Lindsay Pacheco. She is our social worker, which we have had for a year, and she has truly been a wonderful addition to Home Project, because even though we tried to help with resources and social services before we had a social worker, it certainly was kind of just piecemeal, and it wasn't as good as it could be. And then through the generosity of United Healthcare, we were able to get a grant to hire Lindsay, and you all heard from Lindsay on the panel. So she is somebody with lived experience, and so really, I think, contributes a different perspective than if we had just gotten any social worker, right? So we are very much trying to keep her because the grant is ending. But we definitely don't want to lose her. So we will do whatever we need to keep Lindsay on board because she's been great. And then I don't have their pictures up here, but there are 3 lead managers, and so they are kind of in charge of all of the managers of the clinic. So the second years serve as managers, and actually I think the applications or the shadowing for those interested in being managers is starting already. So the lead managers this year are Michael Ajimura, Jake Wakahiro, and then Miranda Edens is our specialty clinic lead manager. And then we have lead volunteers. So we have around 50 volunteers. And so we have 3 lead volunteers that help us to coordinate them. And that's Kylie Takanishi, Faiza Nejad, and Desmond Talia. And so this is the Evie Lay Clinic. Okay, so in case you have to go there, the address is Kuili Street, and this is actually going to be sent to you, but the address is Kuili Street, but actually you can access the building on either Kuili Street or Ka'ahi Street. And it's not like you can go directly into these 2 roads. They're kind of far apart from each other. So if you were to exit out that entrance, you would have to walk along it's probably 6 blocks to get around, because you have to go out, go on King Street, and then come this way. Okay, there's no direct road that goes there, which is crazy. So during the weekdays, you will park at PetSmart and then just walk. It's very close. This is the regular IHS shelter right here. And this is Ross and PetSmart. But for night and weekend clinics, then you can park in the back parking lot. But that one, you have to enter through Ka'ahi Street. Okay, so, and right now, because there's been construction for like as long as I can remember, but you can't make a left turn from Dillingham, so you have to come around from Costco side and then go on Dillingham and then make a right turn onto Ka'ahi. Okay, and so there's no address on that side, so we give you like the closest address that we can if you're going to put it in your GPS. And then it takes you just basically go to the end of the road though there, and then you turn right into the parking lot. And then you can park in any of the visitor stalls or the UCP stalls, but only for nights and weekends for now. And then the IHS Women's and Children's Shelter is on that corner of Ka'ahi Street. And this is kind of what our clinics look like. So for the first time, before we had Iwilei Clinic, we never had patient rooms. Like our old clinics at JOC in Chinatown, as well as our old Kahua Clinic on Pauahi Street. It was basically just kind of like curtain barriers between the exam areas. And so, it wasn't the best privacy for our patients. Physically, they had privacy, but people could still hear conversations and things like that. So it's really nice. We have 3 patient rooms now. And it very much looks like a regular clinic, which is really what we would like to provide for our patients, basically. It has a large storage area, and the upper right picture is of our conference room area. So there's 2 big tables that you guys can sit on and do your work or talk story with the other students, those kinds of things. And then there's a back room that has more storage and like our pharmacy and lab area. So that is our Kahua Clinic. So it's still called Kahua Clinic, which is what it was called on Pauahi, but we just call it Kahua at Iwilei. This is where St. Augustine's Church is in Waikiki, and it's on Ohua Avenue. It's kind of almost, it's very near to Waikiki Health Center, if you know where Waikiki Health Center is. And then we work out of the parking lot in the back of the church. And so we just basically set up the vans and we set up tables and see patients out there. And this clinic is done in conjunction with Revive and Refresh, which is a mobile shower unit. And so patients can take showers, they can get free meals there, and they can also do some laundry through Revive and Refresh. They're a wonderful partner for us. This is the Paiolu Kaiaulu shelter. And so this is in Waianae, okay? And it's almost impossible to get lost. It always baffles me when people get lost because basically you get on the freeway and you just stay on the freeway the entire time. Okay, so H1 turns into Farrington Highway, but then I think what happens is people get to Nanakuli and then they're like, I can't find the clinic because you're in Nanakuli. Okay, so people think everything past like Aulani is Waianae. That's not true. Okay, so some people have never passed Aulani, by the way. Like that's where it stops. So there's Nanakuli and then Maili and then Waianae and then Makaha. Okay, so lots and lots out there. So you have to get past like Waianae Coast Comprehensive Center, and then you're going to get into Waianae Town, and then it'll be on your right-hand side after you cross this like little river stream thingy. And you can't miss it because it's like these big tent-like structures. So this is what the structures, it's like military kind of tent structures. So there's 2 tents like this, like that looks like this. And the one that's closer to the park side is where the families stay, and then the other side is like couples. So it kind of looks like this inside the tent. So there's these structures so that there are individual rooms, but the rooms, so they kind of look like that. They have like a little shelf and a bed and things like that. But there's no like ceiling to the room, so it's kind of open to the rest of the tent and things like that. So it can get very, very hot in there. So they have like these big industrial fans that provide circulation. But so that's one thing to know about for Kahua Clinic, sometimes it can get very cold. And then for Waianae Clinic, sometimes it gets very hot because we have clinic outside. So just want to maybe consider that when you're deciding what to wear. But we basically set up our clinic in the back of this first tent here. And we just see patients out there. And if we need to do private exams, then we take them into the van. And then this is where we have our Thomas Square Clinic. So it's at the upper right-hand corner of Thomas Square. If you're like looking Malka, okay? And so it's like across from the Honolulu Museum of Art. It's like diagonally across First United Methodist Church. So we used to have our clinic in First United Methodist Church for a long time. And during COVID, they stopped they used to serve breakfast to the houseless on Sundays and have like a service for them. And then we would come in after the service and have our clinic in their kind of dining area, which was really nice. But yeah, they stopped doing that during COVID and they've never restarted it. They actually still pass out breakfast, but they don't have like a service or anything. So most of the patients that we used to see at FUM are at Thomas Square anyway. And then we just kind of set up our clinic in the upper corner with tents and our van. And yeah. Okay. And then we also have specialty services. So our specialty clinics are usually on Tuesday evenings, except for psychiatry. Psychiatry we have every Wednesday. The rest of the specialty clinics are once a month on Tuesday. So we have ophthalmology. We are going to be starting neurology, hopefully in September. Actually not in September. No, I know for sure we're not. So probably October we'll start neurology. Women's health is on the 3rd Tuesdays, and then dermatology on the 4th Tuesday. If we need other types of specialty care, we do have a large network of physicians in the community that we can maybe send our patients to, and they'll see them for free or like at a discounted rate. The majority of them are like all of our alumni, so that's very nice. And then if you say you're like at Thomas Square or St. Augustine's and you want a patient to be seen at specialty clinic, we do have transportation services available. So, even if they don't live around the Iwilei area, they can still come to our specialty services. And a patient actually does not need to be a home project patient to come to our specialty clinics. So sometimes we get other clinics that see, so sometimes Kalihi Palama that might see houseless individuals will refer to our specialty clinics, like if their patient doesn't have insurance or something like that. Okay. So, as you know, COVID is not gone away. So, and it's been creeping up steadily over the last couple months. And right now, Hawaii is in the top 3 states of the numbers of COVID, which is not good. These are all things we should not be proud of. Houselessness and COVID. Okay, so we don't have strict protocols anymore though, but you are encouraged to wear a surgical mask for any patient encounter because you never know, right? Who might have something going on. There are many masks at the clinic, so you don't have to provide your own. We have surgical, plus we have N95s and KN95s. Any patient though that has a respiratory illness, you should be wearing a KN95 or an N95 when you go into the room with them, okay? You do not need to wear eye protection unless you're going to be doing testing. So if you do like a point of care COVID test, and that's because they can, oftentimes they might like sneeze or cough on you when you're doing the test. So you should be wearing a mask and eye protection, plus or minus a gown. As long as you're not like touching your clothes and stuff, or some people just want to wear a gown because it protects their clothes. But it's not mandatory. But yeah, you should be wearing eye protection though if you're going to be doing testing. And we do have like goggles and face shields there as well, so you don't need to bring your own. And the patients are encouraged to wear surgical masks, but they are not required to. For respiratory illness, though, we have been telling the volunteers to have the patients put on a surgical mask as well. And then, there's lots of sanitizer all around. There's sinks, so please wash your hands and sanitize frequently. This was, you can tell, like, this is the beginning of COVID because, like, these are, like, the face shields we had to make ourselves because, like, there weren't enough supplies. Like, isn't that crazy? Like, we made those from, like, foam pieces. It was wild. Okay. So these are the services that we provide. So we're basically like a regular clinic, We can provide acute and chronic medical care, preventative health services, advanced wound care. You'll do a lot more wound care at home project than you probably will any place else in your training, which is great because when I was a student, I didn't get any training in advanced wound care. Basically, all of the wound care we got was mainly through surgery. And it was mainly like wet to dry dressings. Like that was it. That was the extent of our wound care. We do a lot of immunizations and TB testing. We can do minor procedures. So, like laceration repair, if we need like cyst removals or like finger or toenail removals, those kinds of things. We do vision screening and we can refer our patients for free glasses through lens correctors. We do a lot of education. We do provide free medications for those that don't have insurance. Otherwise, we go through their insurance. So we have our own kind of like pharmacy formulary. We do mental health assessments and referrals, social services through Lindsay. We give out a lot of patient supplies. Sometimes our patients just come in for the supplies, and that's fine too. But many times they come in just looking for that. Diagnostics, so we do have point of care ultrasound there that we can use for certain things. We do have point of care labs, so HIV and hepatitis C testing, hemoglobin A1C, hemoglobin, lipids, group A strep, influenza, and COVID, and then obviously urine dips and pregnancy tests we can do. And then we recently got an ISAT, which is really nice, which it can do chemistries, but it is not currently working because it has to be calibrated and they lost the calibration cartridge. So we are waiting for the cartridge to be shipped to us. So. And then again, specialty services, and we will be starting our dental clinic, and that hopefully that is starting in September. So here's the people that you need to know other than the leadership team. So volunteers, we have a lot of volunteers. They're mostly pre-meds, but not all pre-meds. Please, please, please be nice to our volunteers. They are wonderful. And they probably know way more about the clinics than you guys do, unless you were a volunteer. So thank you to those of you who are volunteers. And it would be great if you could like learn their names, so not just like, hey, you. Like if there's downtime, they love talking with the med students, and a lot of them are trying to get into medical school, so your advice is great for them. So please take some time to get to know our volunteers. And then first year and second year, you come for clinical skills once a unit. And then you can do an elective during MD5. So we have students that do like a preceptorship with home clinic. And so it counts as one of the MD5 electives. And then managers are our second years. Third year, you come as part of family medicine clerkship and are the main providers. And then in fourth year, there are 2 electives that you can sign up for, a longitudinal clinic elective and then the leadership elective. We also do have residents. So the UH Family Medicine residents come through. Tripler Family Medicine comes on Mondays. Kaiser Internal Medicine comes frequently. It's an elective for them, but we usually get a fair number every year. And then UH Internal Medicine just approved an elective, which we have been trying to get for 20 years. So that is amazing that they finally approved it. We have a lot of volunteer attending. So other than like the leadership attendings, mostly all of our other attendings are volunteers. So, you know, some of them come only once every 3 months, some of them come once a month. But they all give of their time to supervise the students, so that's really nice. And then we are an interprofessional clinic, and so we have other health profession students working with us and health profession faculty. So we have social work students. Right now we have 2 social work students. We have psychology students sometimes, health admin even. Pharmacy students come with one of our family medicine pharmacy faculty. Once in a while, we'll have nursing and public health students as well. We are trying to formalize our interprofessional clinics a little bit more, but it's a challenging thing. Dr. Palmer is very much involved in that effort, and so you know we hope to formalize it a little bit better. It's the perfect place to do interprofessional training, and now that we have like a large space as well, it's even better. So we're hoping that we can do that, because right now most of your interprofessional training is all like virtual, so that's not as good. So this is where you're going to be mostly for the first 2 years. These are just a bunch of the patient supplies that we can give out, but it's not limited necessarily to these things. So if there's something that you feel your patient needs that would benefit them, not just like, oh, you know, I want an Xbox, like not like stuff like that, but do they even have Xbox anymore? I don't even know. But if there's something that you feel is important for them, then just let us know and we can probably go out and get it. So like, for instance, there was a patient that was having a lot of mobility issues, and so was basically laying down most of the day, and he was getting these pressure sores because he was lying down on the concrete basically. So we were able to kind of get him like a mat that he could, like a foam mat that he could lie on, and that was very helpful to him for his pressure sores. So you know, things like that you feel like would benefit them. There's also, so when you go to clinic, there's like a little alcove that has all of our patient supplies, and then across there's like clothes, and there's like barriers like blocking it off, and that's because when the patients go to the bathroom, they have to go through that room, and before we had the barriers up, they would just like stop and then just like go shopping. You know, so that's why there's barriers there. And so it's better like not to like bring them there and say, hey, what do you need? But you know, if they say they need something, then you go and get the supplies. Okay, so try not to like bring them to the supply area, because then we do go through a lot of supplies every month, like tons and tons of supplies. What to bring with you? So you should bring your stethoscope. The otoscopes and ophthalmoscopes are no longer required for your class, and so we do have enough of them at clinic, and so you can use those items there. Please bring a pen. Now you may think like, okay, but you have electronic medical records. Everybody always needs to write something down, and what happens is that you guys steal the volunteers' pens. Okay, and then they're like, I don't know why we don't have any pens, and it's true. Like somewhere there's like an abyss of pens or something. But please try to bring your own pens, okay? And then most importantly, bring a good attitude and an open mind, because that's really going to be quite important at home clinic. Okay, some other things. Home clinic is a student-run clinic. So across the country, many medical schools now have student-run free clinics. Actually, Dr. Schiff and myself are on the board of the student-run free clinic faculty association, and so we interact with a lot of these faculty from other free clinics. And there is a gamut. There is like a range of what student-run means. So in some schools, it's very, very, very much student-run, very little faculty involvement at all. And frankly, it's a little scary, some of those schools, because their students are just kind of going rogue. a little bit. I don't think it's very safe. I don't know how their universities allow that to happen actually, because that's a big liability, I think. And then there's clinics that it's basically faculty run, and then the students just kind of volunteer at it. So we're kind of in between, I think, but over the years, I think we've tried to make it more and more student run. And so that's why we have, the lead managers and lead volunteers, and they're very integral in making policies and in kind of deciding what happens at clinic and running the overall day-to-days of the clinic. So it is a student-run clinic, and so that means though that all the students, so not just the managers, not just the third years, everybody is responsible for that clinic. It's like when you are at clinic, that is your clinic, okay? It belongs to all of the JABSOM students, not just, the third years or the managers, okay? So you should take pride in the clinic when you're there, and you should treat it like it is your clinic, okay? So for example, I'm sure many of you worked in doctor's offices, right? Before coming to medical school. And when you go when you go to your doctor's office, right? You don't see stuff just scattered all over the place, right? And left out. And, so that shouldn't happen at our clinic, right? I mean, we should have the same pride in our clinic that we would anywhere else. Okay, so just kind of keep that in mind. And everybody should help with setup and cleanup, right? Except our volunteer attendings shouldn't have to help with that. Okay, so when we recruit our volunteer attendings, we tell them you don't actually have to know anything about home project. All you have to do is the medicine. We just need you to supervise the medical students and make sure that they are practicing good medicine. Okay, I mean, a lot of them learn a lot about home clinic, but basically that's what they're there for. Everything else is supposed to be the students, okay? So, so everybody should help out. Please keep an eye on supplies. Never ever leave an expensive piece of equipment alone with a patient, okay? Because that is just gonna disappear. I mean, it's not always gonna disappear, but that is how we lost cell phones and other things like that. So don't leave the vision screener with them, or also don't just leave it, which is how we lost one of our vision screeners, which is $8,000. Okay, so just things like that, we have to be more careful about. Okay, if you have a question, please ask. Okay, there's no stupid questions. In your mind, you may think oh, this is a stupid question, or they're going to think I wasn't paying attention or something like that. But it's way better to ask if you don't know something than to make a mistake, right? So please ask. Put everything back where it belongs. Okay, there is an inventory database to help you if you don't know where things belong, or just ask the managers. And there's an end of day log that the volunteers will go through at the end of every clinic. So if there's things that are missing or that you need, then make sure you tell them that during the end of day log. And then, actually, you don't need to worry about that part. Okay, so things to keep in mind. So we don't bill at all. We provide 100% free care, no matter if they have insurance or not. And there's many reasons why that is the way it is, but we will never bill, okay? So, but we don't turn away people with insurance, okay? So when you ask somebody if they have insurance, you should probably preface it by, oh, do you have insurance? Don't worry, you don't need to have insurance, but do you have insurance? Because if you do, then that will help us to get your medications. And that's why we need to know if they have insurance or not. Because medications is one of our largest cost centers. And so if they do have insurance, we should be prescribing them meds with a prescription that they can pick up, or we can even pick it up for them. Actually, 5 Minute Pharmacy now delivers meds to us. So, if that's the barrier, we can get it for them. But if they have insurance, it should be a prescription through their insurance. Okay, unless it's not covered through their insurance, then we'll pay for it. But that's why we need to know. Okay, not because we're going to bill. Language barriers sometimes are an issue. We do use Helping Hands Hawaii, and they have usually all of the different languages that we have problems with at our clinic. If you are going to use them though, please let Hunter know so that we know when the bill comes, because we have to pay for those services. So also, you need to, like when you're using those services, you need to be ready to use the services, because if they call back and you're not quite ready yet, we get charged for the whole time. Okay, like while they're waiting and stuff like that. So please make sure that you're ready. Always, this should go without saying, but always treat the patients with the same respect as any patient. They definitely deserve the same standard of care, right? And so this is a tricky issue, I think, and something that actually the Faculty Association has been discussing, because some people feel that student-run clinics are horrible. Like that's like why would you subject patients, the most vulnerable patients, to students? Like that's like, oh, they don't deserve to have regular doctors, right? But if they were getting that care from regular doctors and they had no access issues, no other issues why they couldn't go to these doctors, then of course everyone should be, have the same type of care, right? But we are providing care for patients in this gap, right? We're not trying to steal patients away from regular clinics, right? Actually, when we first started, the community health centers thought we were going to steal their patients. I don't know what made them think that. Why would we steal their patients? That doesn't make any sense at all. And then they realized over time, they're just taking care of the patients that can't come to our clinic, okay? And we try to get them back into the system to go to those clinics, right? So we're not encouraging our patients to think of us as primary care. Now, we are the primary care physicians for some of our patients, because some of our patients will never go. They will never go back to a regular clinic, and that's okay. We are fine with that, because there's different reasons for that, right? But for those that will, we help to be the bridge to get them back into traditional healthcare, right? And so that's one of the things we're trying to do. So when we talk about standard of care, yes, when we were at our Pauahi clinic, we didn't have individual patient rooms, and standard of care would be individual patient rooms, right? With, privacy, right? But we do what we can, right? And we always strive to be better and do what we can with the resources that we have. And so I think that for naysayers about student-run free clinics, I don't think they're seeing the whole picture of what is happening. But I think it's something for us to think about too. We shouldn't ever just think about it as we're educating you folks or our residents. That is not, even though that's part of our mission, that is not the main mission, right? The priority is always the patients, right? It always has to be the patients. And so we want to provide the highest standard of care that we can, okay? So when we were first starting Home Project, my class was having a reunion, and my medical school class. And so some of my classmates knew that I had started this project. So they were trying to get my classmates to donate money to the project, which was very nice of them. And because back then we had nothing, basically we started off with just a whole bunch of donated stuff, right? So our otoscope was my old otoscope from medical school. And back then, it's not like I went to school in the Stone Ages, but we had these otoscopes. They were silver. They're not the nice black ones that you guys have now. They were silver. And in order to charge them, you had to unscrew the top part and then plug the base into the wall and then screw back on the top part. And so over time, the threads would kind of like loosen, and so like the top would kind of like pop off like really easily. So like I had to like kind of like duct tape it together. And so like, like that was like our otoscope. And then, and so when we had enough money, like we replaced those things like with, like a good otoscope set and a good blood pressure set. And so one of my classmates asked me this, he said, well, what are you going to use the money for? Like if I donate? And so I was telling him like, okay, medications and like, like this equipment, because right now, like the otoscope is my broken otoscope. It's not broken, it still works, but it's duct taped. And he's like, who cares? Who cares if it's duct tape? Like they're houseless, so they should just appreciate whatever you're providing for them. And I was just like, please don't donate to me because I don't want your tainted money. But he doesn't practice in Hawaii actually, so don't worry. You don't have to subject yourself to him. He's actually still the same kind of person. He's a plastic surgeon. Not saying anything about plastic surgery. Sorry. He's not a plastic surgeon. He's a vascular surgeon. And not saying anything about vascular surgery either, because there's some wonderful, wonderful vascular surgeons out there. He just is not necessarily one of them. So, but it's that kind of attitude that I feel like a lot of people in the community actually have though. Like it's more pervasive than you think. And so we want to kind of fight against that. Like, oh, they just deserve whatever they get, that shouldn't be what it is. And yeah, again, ask if you need to. Remember, your priorities may not be the same as the patient's. Think about like what we were talking about before. If you're worried about what are you going to eat, where are you going to sleep, the last thing you're going to be thinking about is your health, right? Be aware of resources. So a lot of what you're going to learn at home clinic is not necessarily like about like disease management or like meds and things like that, but it's about resources. Like number one, what kind of resources do people need and how do you get them and what's available, right? And Lindsay is a great resource for that. And we also have a resource database that you can go through and you can actually help to update as you go through it as well. Houseless patients oftentimes will doctor shop. So maybe like they went to Waikiki Health Center and then they went to the ER that day and then now they're coming to home clinic in the evening. And you're going to be like, what? Why are they, they're coming to see the same, they're coming to be seen for the same thing. But a lot of times, number one, maybe they felt their issue that they felt was most important wasn't addressed, right? Or sometimes they just need somebody to talk to, right? And have like a normal adult conversation with, right? And so for whatever reason, we don't turn people away like that, okay? And patients with mental illness can be difficult. So, of course, you need to be respectful, but you need to always keep yourself safe. This is, and we're going to talk a little bit more about safety in just a bit, but this is the website. And so the on our hawaiihomeproject.org website, at the end, there's a student login. So you can all log in to this site with your hawaii.edu email addresses. And then it will take you to the resource page, which has like a lot of the common forms you're going to need. It has the contact information for like volunteers, managers, attendings, lab resources, like how to do the point of care labs and things like that. So that is all available to you. And then our EMR is through Athena, and you will all be getting login information to Athena. And then there's like a brief video about the basics of using Athena. As first and second year students, basically all you'll probably need to know is like how to input vitals, okay? But I mean, by the way, if a third year ever tells you to write the note for them, like don't be fooled, okay? It is not your responsibility to write the notes. Okay, so that is if you want to have that experience and they are helping to guide you, that's fine. But it's not your responsibility to write the notes. Okay. Okay, we're gonna take a little bit of a break and then sorry, let me finish. Okay, you know what? Let's take a little bit of a break and then we'll come back about the specific objectives you have, and then we're gonna talk about crisis intervention. Okay. 10 minutes. Come back at 11.
Did you want to meet up later to work on meetings?
You know, we are sorry, it wasn't for me. Oh, that question. Tell Miranda that you maybe you can just shadow one of the other clinics because since we don't have a neurologist clinic yet. And then but when you apply there will be an option. Yeah.
I need to make a calendar.
I have you know what's going on. No. Have your shadowing seen my birthday last year. Well, I don't know. I really liked her. I might just bring it in case she's 7. Thank you. I'll bring it back tomorrow. Yeah. No worries. Scratch Catherine.
Oh.
Yeah, thank you though. Thank you. Okay. I appreciate that. September 30th. Friends.
Go ahead.
I just have a question.
Oh, for me?
Some of us still haven't found out our name.
That's what I've heard.
Yeah, what the heck?
Yeah, what
Wes?
the heck?
We're gonna.
Yeah, what was your number one?
I think it's just Wayfinder and Jess that haven't found out.
Yeah, I contacted both program directors yesterday. Their selectees. Wayfinder said I did not hear back from them. So you were in those programs?
I'm in Wayfinder because I ranked that 1.
Oh, then you're in Wayfinder.
Like Chef, like 7.
Oh yeah. Then you're in Wayfinder.
But yeah, okay.
And I got an immediate email back going, got it, we'll do.
It's like,
Okay, yeah.
and then just the program starts September 30th. When does it start?
Yeah, so September 30th. So we have the colloquia on September 23rd for MD2. And then the following week is when I'll start each individual.
And then do you happen to know when the you might not know because you're not in. Are you in? You're not in MD2 course. Are you in?
What is your question? So it usually comes out 2 weeks before the 2 weeks before the course starts.
Is it like a similar setup like for MS1? It's just gonna be like Monday, Thursday.
It's always Monday, Thursday PPL, even in second year. And then Tuesdays is always safe for community health. Wednesday and Friday is always lecture in the morning, and then Friday afternoon is anatomy, and then Wednesday afternoon is either clinical skills or learning.
Okay, so the structure will be the same.
Yeah.
There's just no managers right
This is a curiosity question. So I know we had to rotate throughout the first year and the home clinic. Do we have the option to put it line night too, like town clinic?
No, I think that Wina is and so if you have a particular interest in going there, you just need to let Lauren know, and then she can schedule you at that clinic. Because some people actually don't want to go.
I think
because it's really far. Yeah, so.
But I actually live closer there. Save the drive into town.
Yeah, if you let Lauren know, I think it'll actually.
Yeah, then she can accommodate.
Yeah. He's not doing work. He's like adding stuff up. So that's what I'm doing right now.
Oh yeah.
Yeah. I was growing up on that. You're doing like a one or
I checked yesterday. I precepted last Monday, and we were like overflowing with students. It was like, oh my gosh.
Because I noticed like a lot of our classes like, oh, this is like that, and I'm like, not for me. I'd rather go there.
I do like that.
You're so right. People get the money, and it's like,
I know. Occasions when ophthalmologists use their stethoscopes is not very often. We actually do have stethoscopes at the project, so you probably don't need it. Probably Yeah, so there's these shelves in our conference room area, and it says place bags here, and that's where you would after it can get pretty cold. Yeah, unless the air conditioning isn't working, and it's super hot. Yeah, but I mean the air conditioning is usually working.
No. Okay, so you're gonna bring your stats.
I'm giving this back to Oh, you just asked? I put my eye back donor that was very interested in like to start a religion. I just wanted to go to there. Like super Friday night, negative Saturday. But then sorry, I lied. So we don't eat it. I feel like we should be fine. It's been all 5 days already. I mean, she wants to go. I mean, later for Sarah, specialty. She does, but she works at Sorry. I know that's bad. Honestly, like some people at our clinic, like they don't even know. It's just like so I don't even know what I want that. We never talked about that. Like no one's ever just the volunteers. So I was like, I mean, they would even like cross the line. I'm like, I'll get to move back to the but I think I not supplies, like when I suppose I like going up with the last like learn everyone's styles, like people like Paul stuff would be like, no, they won't like that. Like depending on the class. Yeah. And then like or like everybody's so I was like making me feel like water rooms and like makes sense. You know, like just kinda like when I'm like stuff like that. I just like talk to them.
No we like check them in and then tell them messages why they're there.
Okay, I will let we're gonna get started again. So in terms of what you're supposed to be doing in the first 2 years when you go for clinical skills and community health, there's some general objectives overall. And so one of them is that hopefully by the end of the first 2 years, you'll be able to describe common presenting problems of those experiencing houselessness. You'll be able to discuss how diagnostic and management strategies may differ in caring for patients who are houseless compared to the general population. And then describe common non-medical needs that houseless patients have and the resources available for them. So those are kind of our overarching objectives for the first 2 years. But every unit, you're going to have unit-specific objectives. So you will be going to home clinic once per unit in all of your units, except for MD4, you will go twice and the reason for that is in the other units, there's not enough clinics because the second years are going as well, right? So there's like, oh, you're only going once now? Okay. Oh, you're only going once now in MD4.
You can go a second time in MD4 because there aren't as many students, but we're only scheduling.
Oh, okay.
Yeah, one per unit.
Thank you for that clarification. So it's basically a time for you to practice your clinical skills with, in the real world, right? And so that's why it's kind of unit-specific objectives that we have. You will get a lot of mentoring from the MS3s and MS4. So basically the MS3s are going to be like your direct supervisors. And so they are the ones that are actually going to be signing you off on your cards, okay? The managers also will be starting their application process. So many of you came to the informational session last week and shadowing has already started. So you can sign up for those. And then there are other volunteer opportunities as well. For the specialty clinics, it's mostly third and fourth years that we kind of are trying to recruit to see the patients because in the past, the specialty managers had to write the notes because there were no other students there. And basically, you guys don't know what you're doing. So it was really hard for the managers to write those notes. And specialty notes sometimes are very different than regular clinic notes too. So we actually have, I believe all of the clinics are full now with 3rd and 4th years. So that's good because they can help you. Specialty managers will still get experience with the patients. It's just that they won't have to write the notes, which is good. But then in addition to what you're assigned to, if you want to do extra kind of clinical experiences, then you can let us know. Sometimes, students want to start a new initiative, and so it's not a guarantee, but we're definitely open to new initiatives. Many of the things that we do have been student-driven, so I think that's great. And then we have a lot of other events, and we do a lot of things for like the kids, the houseless kids that we work with, and so all of those are opportunities that you have to engage with Home Project. And I know that there are a number of you that have expressed interest in helping out the Boat Harbor encampment. And so I am working with Kala to figure out what's the best way that you guys can help out. And he's very, very appreciative. And we'll figure something out that you guys can definitely help with. So this is an example of your card. So every unit is going to have a different card, and it will tell you what the objectives are for that unit. And then on the back side, there's like a check off. So the MS3s will initial after you complete that objective. So like in MD2, when you go, you're supposed to be taking vitals. And so you're supposed to write the vitals there. You should discuss and interpret the vital signs with the 3rd year or above. You're going to do a heart and lung exam on the patient. You're going to collect basic information, demographic information about the patient, and like the pertinent medical history. And then you're gonna, at the end of every visit, you're gonna fill out this Google form, okay? And then you're gonna turn that card into Risa Tanaka. So because this is part of clinical skills.
Is there a clinical skills box in the mailroom?
I think you just put it, in the mailroom, there's the OSA, OME box. So you can just put it in there, and then it gets routed to whoever it needs to go to. So yeah, you can just put it in that metal box. Any questions about this, about your objectives? Okay, we're going to talk a little bit about crisis management and de-escalation. So when we first started Home Project, we didn't even talk about this at all, like hardly ever at all. And it wasn't really until maybe like 8 years ago. Well, when was Wilfred here?
Yeah.
Was that same year? So around 8 years ago or something, we had like our first incident with, and it's kind of amazing now that I think about it that we never had an incident before that. But unfortunately, fortunately, the student that was involved didn't get hurt, but a patient was very agitated, and the student was doing what he thought, was going to be helpful, but it was actually sort of escalating the patient. And then the patient like swung at him and did make contact with him, but he kind of moved back, so it wasn't like a full force hit. And then unfortunately, fortunately and unfortunately, one of the other patients then jumped over the table and started protecting the student by beating up the other guy. Which is good, but maybe not good. So after that incident, we became much more aware of we probably should be doing more training for you folks in terms of crisis management and de-escalation. And some of the students actually worked on different ways that we could do that. So this is, part of, you're going to be working at home clinic all 4 years. And actually, what we're going to be talking about now doesn't just pertain to when you are at home clinic. Things can happen no matter what clinic you're at, right? In psychiatry, you're probably going to encounter more patients that you're going to have to understand de-escalation with than probably at home project. Okay? So there's 5 things that I want to emphasize when it comes to crisis management and de-escalation. I mean, in crisis management, right, part of that is prevention, right? So preventing it from even escalating in the first place, right? But sometimes no matter what we do, it will escalate. So the 5 things are displaying empathy, reflecting the person's feelings, creating a caring and safe climate, being non-judgmental, accepting and respectful, and then staying engaged in the present. Very similar to trauma-informed care, right? Okay, so first of all, displaying empathy. So I think that we all like to think that we're super empathetic people. We came to medical school, all doctors are empathetic, which is not true. Okay, so there are many practicing physicians out there that I think could have much more empathy than they currently do. And hopefully, though, you folks are going to be really good at being empathetic and acceptance of a patient, no matter who they are and how they present and what they bring with them. That is one of the best ways to display empathy. Okay, and it's not as easy as you think it might be. Okay, because I think idealistically, we all think that we are going to always, be caring and compassionate no matter what that person is going to say to me. I'm going to stay calm and I'm not going to let it bother me. And I'm going to tell you that there are going to be times when you are going to be bothered and you're going to have to, pause, like Dr. Schiff mentioned, and really think about what's happening, right? And just as patients have triggers, you guys also have triggers. Everybody has their own kind of trigger that makes them get a little more irritated with a patient than maybe another patient, right? So it is really, though, important to understand somebody's feelings and their perspective of things, because perspective is what it's all about. How somebody is perceiving a situation and how you are perceiving that situation. If they are, not together, then that is going to lead to conflict, right? So it's really important for us to understand their perspectives. And then we want to take a strengths-based perspective of things, right? So especially when I have a really difficult patient and where it's really easy to not want to be so nice. They're being really difficult. It doesn't seem like they're necessarily under the influence or have, a significant mental illness. So it seems like they're in control of their, cognitive abilities, and they're just being, more nasty than they should, right? It's hard to keep that empathy. And so I always try to think to myself, what is the best thing about this patient? No matter what they come with, then if I take the time, well, number one, I think because it helps me to pause, right? But then I really try to focus on, what is the best thing about this patient? What is the most important asset that the person has that we can build off of? And if you start to think like that, then it's a little bit easier, I think. Sometimes you just have to follow let them lead the discussion. Now, I'm not saying that you should always do that, because like when you're dealing with people that have very tangential thought process, like you're just gonna go down a rabbit hole, right? So you need to know when to kind of stop that. But other people, sometimes it just takes them a little bit longer to explain what they're trying to get out, or they want to tell you something, but they don't want to directly tell you, so they tell you kind of in a roundabout way and hope that you understand what they're trying to say. So sometimes just letting them talk it out is a great way to build trust with people, because they feel that you are willing to listen to what they have to say. Okay? And so at home clinic, it really does allow you to do that more than probably in a regular clinic, because we don't have the same time constraints that like maybe a regular clinic has, right? So, I mean, I empathize with, I don't think I could go back to like a billing clinic, because I would feel like too pressured to like have to see patients too fast and stuff like that. It's really nice not to have that pressure. But just because you have more time doesn't mean your patients want to talk to you for an hour, okay, necessarily. Some of them do, but they might not want to, so don't necessarily take up all of that time, okay? And then, okay, reflecting your patient's feelings. So, and this is just standard communication, right? Doctor-patient communication, right? Restating, paraphrasing, confirming, so saying back what they said to you, so that they can, you can confirm that you heard what they were trying to say, right? Asking clarifying questions. Please try to pay attention so that you do not ask the same question that they just answered. And we see that sometimes in our standardized patients, like, then clearly you weren't listening because you just asked them what they just told you. Okay, so that's a sure sign that you are not listening. And so this will demonstrate your intent to understand them and want to really help them. Okay. Creating a caring and safe environment. And what's safe to people is different, right? Like, we're not just talking about physical safety, we're also talking about psychological safety. And depending on somebody's background and what they have experienced, what is considered a safe environment is going to be different for every individual. So you kind of have to know what that patient's background is, right? But showing interest and concerns for their well-being is really important. Just simple statements of concern, like you guys were practicing earlier, that's really important. And then staying engaged and non-judgmental. So being non-judgmental, accepting, and respectful, certainly super important when it comes to crisis management and keeping things from escalating. So remaining objective, again, it's not as easy as you might think it is, but it's super, super important. And so if you feel yourself becoming judgmental, and you can normally tell, unless you have very poor emotional intelligence, which we're all supposed to be building, right? So try to be self-aware of what is happening in your mind and in your body, right? Yeah, like Dr. Schiff mentioned, if you feel yourself getting tense, right, then you know, like, you have to kind of relax. So the first time that I did yoga, you know, at the end of yoga they do Shavasana, right? For those of you that don't do yoga, it's basically just lying down and lying still. And like, that's my favorite pose. I'm like, when's Shavasana? But I remember the first time I did it, and then she was saying, you know, just relax your body. And like, here I am thinking, like, I'm super relaxed. And she's like, I know that some of you, your tongues are like tense on the top of the roof of your mouth. And that was exactly what was happening with me. Like, I thought I was super relaxed, but I was not. And just like your mouth and your jaw, like, can be tense, and that's like a sign that you're not as relaxed as you should be. So just subtle things like that, I think, are important. Definitely showing respect for what is concerning them. Like, even if you think it's like, why are they worried about that? You know, they shouldn't be worried about that. But if that's their main concern, if you don't address that concern and you don't have respect for that concern, they're not going to care about anything else you have to say. And they're going to think like you're not listening and you don't care about them, right? So just be aware of that. So if you want a collaborative relationship, you are going to have to be better at kind of understanding your own thoughts as the conversation goes on. So it's hard sometimes to be respectful when people are not being respectful to you. So we had this patient when we had our Chinatown clinic, and like I knew this patient well, and she obviously had mental illness, and she would like just swear all the time. But it's not like she, like it's almost like that was her language. She just swore all the time, and sometimes she would just have these outbursts of swearing. And I was just used to it because she came in all the time, and we were doing like wound care on her one day, and then like I suppose if you never saw her before, like you would think like, what in the world? Because like she was just like swearing at me, and like as I was cleaning her wound, but she wasn't like getting agitated or angry. She was just swearing at me and calling me like pretty bad, words. And so the medical student next to me looked like they were gonna die. They were just like, and I could tell like they were super, super uncomfortable. But we just went on and did the wound care, and then she got up and she's like, okay, thank you. And then she came, she was gonna come back the next day for her wound dressing or whatever. And then the student was just like, I cannot believe that you let her talk to you like that. And I'm like, well, I was not offended, number one, because I know that she, number one, has no control, really, over what she's saying. Like, if I thought she had full control of her thoughts and everything, then yeah, maybe I would be kind of offended. Like, if my brother said that to me, I would be offended, and like, that's very disrespectful. Or Dr. Palmer talked to me like that, like, yeah, he would be fired. No, I'm just kidding. Well, yeah, he might be fired. but a lot of times, and if people are under the influence of substances or they have a mental illness, they are not in control of what they're saying. And you have to realize it. So you have to put it into context of why they are saying what they're saying. Right? And I'm not saying that you need to let people walk all over you. That's not what I'm saying. But there is a time and a place for getting upset, right? And she was not a threat to me. And I knew that she was not angry at me and was not going to hit me or anything like that. And so it was fine, right? And she got the care she needed. She trusts us enough to come back all the time. The same patient one time came in, and she was clearly like not a well-medicated schizophrenic, right? And you can't, well, I guess now you can force them to be medicated, but that's controversial. And then so she came in, and then she just immediately started accusing one of the students of stealing her purse. Like, you stole my purse. And she was like yelling about like how the student saw her. And then the student, instead of just letting it go, was like, I did not steal your purse. And then I was like, she doesn't think you stole your purse. Just say, I don't have your purse right now. And just let her go, But the student got very agitated and was like arguing with her about not stealing her purse. And then that definitely escalated, So I think it's times like that you have to read the room better, and kind of learn how to control your emotions in those situations, right? And it's hard. Sometimes it's very hard.
Can I add something?
Yeah.
just as Dr. Omori was talking, I wonder, and what I was thinking about, I wonder if any of you were also thinking about the ethics cases that we just had last week, just to have a bridge between that content and here. So we had that one case of the young man with meningitis who wanted to leave the hospital and not get treatment, and we talked through autonomy and like, well, if he's not of sound mind and doesn't have capacity, then he probably cannot make that decision, and we need to treat him. And in that context, I think perhaps because it's not controversial, it's not associated with stigmatizing illnesses. I think it tends to be easier to have those conversations about, well, of course he doesn't know. Of course we need to help figure out treatment and then come to a shared decision-making plan. We're gonna see the exact same thing show up with it can be other kinds of infections, but also the things Dr. Omori is mentioning with mental illness, or severe mental illness, or substance use, and the same kind of ethical thoughts about how do we, like, is this person in control of the ways that they are making decisions right now? And what is our ethical obligation in terms of how we take care of this person and offer care to them are still aligned no matter what the reason is.
Thank you. Okay. And then staying engaged in the present. Again, this can be very hard, but a lot of times you may think that a patient is taking something out on you, but they're just needing to take it out somewhere. And you happen to be the person that is listening to them, right? And so I think we all need to, not take things so personally. And again, it really depends on the context of the situation, right? And it doesn't have to, and if you can show empathy in those situations, many times you can turn around the tone of the conversation. And if they see that, oh, this person is actually listening to what I'm complaining about and not making excuses and not, casting judgment on me, then a lot of times that in and of itself will calm them down. Right? And so that's what our goal is. And so we want to be able to build this rapport with our patients. We want to have be able to have shared problem solving, but unless we can get on a plane where we're thinking the same way, it's going to be really, really difficult, right? Okay, so other reminders. So you should always pay attention to your position. So number one, if you feel like a patient is more agitated, then you probably should not go into the room alone. Like, just take somebody with you. And you should always position yourself, and you'll learn this in psychiatry over and over again, but you always position yourself by the door. So you should never be, like, the patient should never be between you and the door. Okay, so you should always be closer to the door. Similarly, if you are like, so where the incident with the student took place, it was at the church actually, and we had these tables that were against the wall like this, and the students would see the patients. And this student had situated himself on the inside, and then the patient was on the outside. And so there was no like escape route once that patient started getting more and more agitated, right? So always make sure that you are kind of on the outside. Staying calm is super, super important, okay? Because if you escalate, when a patient escalates, they're just gonna feed off of that, and it's just gonna keep going and keep going. So you need to be the one that kind of calms down, stays calm. Oftentimes, you can actually get people to start breathing slower if you purposely start breathing slower. So I didn't believe that was true, and so I used to try it out, and it actually works. Not all the time, but it kind of does work. So if you just like purposely start breathing slower, oftentimes it helps to help people be more calm. You do need to respect people's personal space. Okay, so like in this case, and the student was very well-meaning, and so was trying to calm the patient down and basically like put his hand on the patient's shoulder, in like trying to be compassionate, right? But if somebody is in a heightened hypervigilant state already, just touching them anywhere can set them off, right? And that's exactly what happened. And then the patient kind of reacted. Okay, so anytime somebody is really agitated, you need to give them probably more space than you normally would. Okay, or just walk away too. Like give them some time. Give them some time to, get themselves more calm, or for the situation itself to just diffuse. Oftentimes, you don't have to say like, "Hey, you're getting agitated, so I'm going to give you some time." Like, don't say that, right? But you can just say that you have to go and get something, or you're going to give them some time to rest, and then you'll come back and talk to them after a little bit. So there's a lot of different ways you can do that. I think a lot of times when we are uncomfortable, we start to talk more, right? And some people do that more than others. But that is also agitating. So if somebody is agitated, try to talk less and don't feel like you have to, keep talking to try to get the person to calm down. Like that's not going to be very successful. So less is more in that case, okay? Again, with mental illness and substance abuse, you can't take things too personally. Don't try to answer challenging questions like that, that have no bearing on things, right? So sometimes when people are not thinking straight, they're gonna ask you things and you're not gonna know how to answer it. Okay, so instead of just trying to think of an answer or say something, just try to redirect them. Okay, so you don't need to fixate on their fixation. Okay, so just try to redirect them to something else instead of, because then it can escalate, like the purse issue, right? Like there's no sense in that, in engaging in that, right? Okay, your safety is so when I say patients come first, that is true. Like patients always come first. However, what trumps even that is your safety. Okay, so if you ever feel like you are in a dangerous situation, then please remove yourself from that situation. Please call for help. There's always an attending, so make sure the attending knows. If you are at a clinic with Lindsay is actually extremely good at crisis intervention. She's actually certified in crisis intervention, and so she is definitely able to help you. And if it escalates even more than that, do not hesitate. Like if you are in fear of your own safety or like the safety of other people or other patients, then please do not hesitate to call 911. Okay? However, we do not call 911 just on like, oh, this guy looks a little shady. Like, we do not call 911 for that. Okay? So we have to be very careful that we're not contributing to the triggers that our patients have. Right? Okay. CORE is the city's crisis outreach team, and we partner with them quite a bit. They are the ones that are going to be in red shirts, so you'll see them at clinics sometimes. And they can also try to help either calm down a patient or get them somewhere else that they should be. At EVLA, there's also security, building security. Sometimes they're a little too aggressive, in my opinion, but if you feel like you need extra help, you can call the security as well. Okay, so I didn't put this on a slide, but so like I said, in the beginning, we didn't really address these issues very well, and so we've tried to kind of be more more vigilant and more better about preparing you for this. And I don't want you to feel like, oh my God, I'm super scared now, like that this is going to happen, because it's very rare, but it can happen. So we want you to have the skills in case it does happen, right? And I do feel like it happens more than it used to, because before 8 years ago, it never happened. And so I think maybe, we are also dealing with more unsheltered individuals. And I think that there certainly is more mental illness and substance abuse in unsheltered populations. So that's probably what has contributed to the increase in these incidents. But I don't want you to feel like, oh my God, this is going to happen. And every patient that comes in, you're going to be like nervous about that. Okay. In the past, we never restricted access to any patients, right? Because we have a very kind of open door policy, and we want to break down barriers for our patients to receive care, because in many places, there are so many barriers for them. So we don't want to be another barrier. However, there are certain situations when we have tried all we can, right? We have tried all we can to de-escalate, to try to build rapport, to be as compassionate as we can. It's not always going to work, right? And sometimes people just, despite understanding what the kind of rules are and what just basic decorum is, they can't follow those. And they don't have, maybe they are thinking straight, or maybe they're not, but even people that may not have their full facilities, they understand certain things, right? So we do have a policy, and I think that Hunter actually sent it out to all of you before you even went to clinic. So maybe for a lot of you, there was no context to that email, but in terms of restricting access for our patients, if there are, certain incidents and, they go beyond like certain amount of warnings, we do like restrict access for like a week. And then if it continues to happen, then the next time they get restricted, it's maybe like a month, and then maybe even longer than that. We have had to restrict patients after, for a week, but never longer than that since we've started to really pay attention to this. But it's very rare. It's very rare that would happen, and it's only in cases where we've tried everything we can to, help the patient to understand what acceptable behavior is. Because even though we want to be very tolerant and accepting, we also don't want to put you at risk, or for you to feel, like you can't function properly, right, in that environment. So it's very rare, but it does happen. And so if you find yourself in that situation, please, please, please let somebody know, okay? But we should try all of these things, and we should try to, the biggest thing is giving people space. Like that's probably the number one thing you should do, is to give people space and time to like kind of calm themselves down. Because oftentimes that will do it, okay? Oh, I did want to say one other thing. So when we were at IHS, so people on the street that live on the street, it's scary, right? Like it's scary to have to live on the street, and you have to protect yourself. And I mean, people are scared of people that live on the street, but people that live on the street are scared of people that live on the street, right? And so many people carry protection with them. So like knives and things like that, machetes. One time I saw a samurai sword. I don't know how he got that, but it was pretty nice. So you might feel like threatened because you see that they have like this like axe or something, right? But just realize that a lot of times they have that because that is their form of protection, right? You can ask them, and almost all of the time they will totally abide by it, but you can say, I really understand that that's really important to you and that you need that, but while we are having the visit, would you mind leaving it at the front desk? Okay, so obviously they shouldn't be bringing their axe into the patient room with you, right? But the majority of the time, I have never I guess it could happen. It could happen that they want to like chop you up. No, I'm just kidding. You know what I mean. But regardless of what their intention is, it's always best policy to have them leave weapons at the front desk. Okay. I don't think we've ever seen a gun. I don't think we've ever seen a gun. Okay. Any questions about this? Or situations that might happen?
Or maybe I'll just add to the weapons thing, because those of you who have been at Thomas Square might have been here during this incident. But so we were at Thomas Square, which is an outdoor park, and there was a gentleman not being seen at our clinic, but kind of nearby with a large axe. And we were feeling uncomfortable, just like this person was acting with some like kind of unpredictable behavior, and we were worried that they might come over to us, So anyway, I went with another student to go and find a police officer, and basically what they said was, I think their phrase was strange but not illegal. And so they said basically, like, there's nothing we can do about people having a weapon if they're not like doing anything that is dangerous. And then the police officer reminded me of, did you see this? There's this guy on a moped who rides around with a samurai sword, and he was like strange but not illegal. And so anyway, the reason I bring that up is that the situational awareness piece of it, like how we look out for each other, is really, really important. And a lot of times it's the person who's not directly involved in that little space to be able to see what else might be going on. So you can help people move away. You can let the attending know if sometimes if we're in an outdoor space, we need to actually move all of us, move away. And so most of the time I agree with Dr. Omori, the patients are like, they have the protection for themselves. It's nothing really to worry about. A lot of times they'll like keep it concealed and it's not an issue. But yeah, keep an eye on each other, I think, is really important.
Okay, so we're going to do one last exercise, and for this, if you can maybe get into like groups of 5 or 6. So basically there are going to be 4 different patient scenarios, and so I'll just like figure out which patient you're gonna do. But this is a QR code that will take you to the different patient scenarios. So there are 4 patients: Joe, Maria, Jeremy, and Rosie. Okay. And in your group, after reading the patient scenario, I want you to identify potential verbal or nonverbal triggers that this patient might have. And then we would like you to brainstorm some tools that maybe you could use to de-escalate the situation. So whether it's something you say or something you do. Oh, is it the first one? No tsunami, don't worry. What if there was a tsunami on this day? Then what about that? That would be weird. Okay, so and then we're gonna share. Okay, so maybe so get into groups of 5 or 6, and if you're like in this quarter of the room, you guys are gonna do patient 1. If you're in this quarter, you do patient 2. This quarter you do patient 3, and last quarter you guys do patient 4. Okay? So you guys can talk about it for maybe like 5 minutes.
Do you guys want to go together or let's do it?
I'm not working. Oh.
Just stand up.
Oh my god. The wrong name.
Should we do patient 2 or 3?
I guess now we're on
Possible like
Jeremy has combat related
Verbal reminders.
Like his reasons for being hypervigilant.
I would have signed up. But then now I'm here. So now I'm like, well,
Create a de-escalate strategy.
I could, but I also
I know what it's saying, but it's not in English.
I need to go home and do that I didn't know 5 years to learn, and now I kind of want 5 years to learn.
Oh my god,
It's like the side.
well, only the first
I don't know. I couldn't do that. Wait, he doesn't want to do it. Okay, and he's done pretty close to it. Just
It's along those lines, like it's getting well.
So I can accept it, like I just look forward to it. Sounds like not
what is that?
I'm more obligated not to.
I always forget.
Is pre-colonial and modern day San Francisco.
We're stuck in Milwaukee for 40 minutes. With a single car.
The wording is I keep parking at the bus.
Yeah, so you might want to.
I use it as like the baseline, and then I'll like I mean, sometimes I just skip it. I'm like, I'll just read it
Right. Are you guys kind of set to share? Okay, we're gonna start with if you did patient 1, can you raise your hand? Like there were about like 4 groups maybe. 3 groups maybe. Okay. So can somebody read out the patient scenario? One of you guys. Don't all jump at it.
I'll read it. Joe is a 62-year-old part Hawaiian male. He's a former carpenter who lost his housing after being priced out of his rental. He now lives at a beach encampment on Sand Island and frequents the clinic for chronic leg pain and poorly controlled diabetes. Joe has witnessed and experienced systemic racism throughout his life. He was incarcerated for nonviolent drug charges during the 1990s. He has had multiple negative experiences with law enforcement and healthcare providers. He has been estranged from his family for 20 years.
Okay. So the groups that did patient 1, what did you identify as being some potential triggers for Joe?
Police presence or even healthcare providers.
Okay. Maybe we can go like round robin to the groups. No, I think that's good. Thank you for going first. How about that group?
Anything involved with like his race or
Okay.
because of the systemic racism.
Okay, yeah. Even maybe well-intentioned things, right? Okay.
Kind of aligning with police presence, we talked about potentially uniforms being a trigger.
Yeah. One of the reasons we actually don't wear white coats at our clinic. Okay, was there another group?
I was gonna say discussion of like family dynamics.
Yeah. Which we don't always think of as triggering, right? But certainly for a lot of people. Any other ones that people did not say that you guys thought of? Okay, What about so other things that maybe to think about for Joe's situation. So, like authoritarian kind of positions, or like if you're more paternalistic, right? Like, and are just kind of telling people what to do, like that's more kind of authoritarian. So that might be triggering for somebody, especially, like when you've been incarcerated and things like that, or have had bad experiences. If you, even if it's because of the experiences with racism and maybe, healthcare environments and things like that, even things that are not necessarily aimed at the patient. So maybe if there was like a super long wait, right, at the clinic, then he might interpret that as like, oh, they're taking other patients before me, like other patients are more important than I am, and those kinds of things, right? Okay, what were some of your strategies in helping to keep Joe nice and calm? Who would like which? Okay, back group.
Avoiding commands.
Okay. Yeah. And so, like, do you have an example of like what a command might be, and then how you could phrase it differently?
I guess starting with open-ended questions, or even if things get escalated, to try to avoid telling him to do one thing or another, whether it be like, like telling him to quiet down or something like that, instead to just remain super calm and to try to not emulate, I guess, probably some of the bad experiences he had in the past.
Like some of the reactions that he may have had, right? Always involving him in making those decisions, right? Okay, great. Other strategies that people thought of?
Kind of along those lines, I think, like when we're like, you need to take your medications, and then just giving him like the power to choose, since he's been in like systems that have failed him and where he didn't have a lot of control, and giving him like these are like the benefits of why you should, but not just like you need to do this.
Yeah. I mean, that is good for all of our patients, really, right? But especially for somebody with this kind of background, right? I think that would be excellent to do. Other things? Did you guys have other strategies, this group?
Ours kind of overlapped, but I think the biggest thing we thought of was he was being super transparent already because of the distrust that he has. So, always talking things out, like what we're doing, why we're doing it.
How about this back group? You guys had any other strategies?
We talked about like not insisting on getting every single part of the interview, like family for one, and then like maybe living situation or substance abuse. Like making clear it's a part of the process and nothing's targeted, but also like if you don't want to answer, that's okay.
Yeah. Great, wonderful. I think also, because maybe he feels like he was marginalized in the past, right? Just allowing like maybe a little bit more time for his visit, maybe allowing him to share more than, you might normally let a patient share, right? Okay, great. Thank you, group one. Okay, this quarter, who did Maria? Can somebody read Maria's scenario?
Maria is a 32-year-old Filipino transgender woman. She has experienced chronic homelessness since she was disowned by her family as a teenager. She engages in sex work to survive and has a history of substance use disorder. She is seeking help for an upper respiratory infection and refill on her estrogen. Maria is a survivor of physical and sexual violence. She has experienced multiple assaults in both shelters and public restrooms. She has experienced past misgendering and discrimination by healthcare workers. She usually avoids police and other institutions out of fear.
Okay, so for which groups did Maria? Only 2 groups? Three groups? Were you guys one big group at that? Oh, okay. All right, so maybe 3 groups? Okay, so what were some of the triggers that you guys identified?
We talked about misgendering, so using like the wrong pronouns, or also just using gendered descriptions in like the physical exam.
Yeah, great. That definitely is a trigger. Others?
Maybe men.
Oh.
I'm assuming, well, maybe she's in the wrong bathroom and has had some altercations.
Yeah.
Yeah, similar to that, is there like a certain demographic of her assaultant? Like whether, like it could be a certain like height or like a certain like voice or like even a certain race.
Yeah, just somebody that happens to look like an assaulter, right? Or even just a situation that brought something on, right? Yeah.
We also said like any quick sudden movements because she's like assault. So any type of movement that's unexpected to her.
Exactly. Yeah, great. Anything else?
Similar to that, we said like close quarters. This might be a situation where you would want like the privacy of the patient.
Yeah. Or she might want more privacy, right? So maybe kind of just asking her what she feels most comfortable. And definitely like, would she feel more comfortable, with a different provider or, something like that. Right? Anything else? How about strategies? What kind of strategies did you guys think of?
I guess this applies for like everybody, but also maybe also for her, like before you were to do anything, like inspect her, say that you're gonna do it, ask for permission first. Like before you palpate, ask first before you do it. If she doesn't want to, then it's okay.
Yeah, be very explicit, about that. Great. Other things that might be helpful? Yeah.
Using gender affirming pronouns.
Yeah, I mean, just simply that, right? I think sometimes it's very, very powerful, which unfortunately now is becoming more difficult, but we can still do it in our care because that is providing the best care and that is not against the law. So, other things.
Avoiding physical touch, maybe because she's probably triggered by that.
Yeah. So maybe in another situation where you might, just casually, like pat somebody on the back or, like even sometimes not everybody likes to shake hands, right? And so you kind of gotta just see, what people feel comfortable with. Yeah. So even that might be uncomfortable for some people. Any other things that you guys thought of? Let's see. I think some things that you guys already mentioned, but yeah, like avoiding the sudden movements, those kinds of things, reassuring confidentiality, right? That you're not going to be sharing, anything with other organizations and things like that, right? That you're going to get her permission before sharing if need be, and it's only if it affects her care or something. Okay, very good, very good. Yay. Patient 3, Jeremy. Who would like to read Jeremy? Okay.
Jeremy is a 29-year-old black male veteran. He served 2 tours in Afghanistan and was honorably discharged. He has PTSD, hypervigilance, and sleeps in his car with his 8-year-old daughter. He presents with insomnia and hypertension, and he's worried about having his daughter taken away. Jeremy has combat-related PTSD and witnessed the death of several close friends. He grew up in foster care due to abuse from his biological parents. He has a history of restraint and forced hospitalization in the VA system.
Okay. So what were some of the triggers you guys detected? Or possible triggers?
I think similarly to patient number 2, Maria, any sudden movements, anything that can be perceived as aggressive.
We also said loud noises.
Yeah, sometimes just the stimulation, right? Overstimulation can do it. Or sometimes it's certain noises, right? That will be triggering if somebody has PTSD. Other things?
Any situation where the daughter isn't with them.
Yeah, or that he perceives that maybe, a lot of times people think you're asking questions to judge his capability of taking care of his daughter, right? And so you have to be very careful about how questions are phrased. Other things?
We also talked about like a trigger could be anything that makes him feel like he's not in control, just because he had the forced confinement.
Yeah, that can be very, very disarming, right? Like sometimes just being left in a patient room by yourself behind a closed door can feel confining to somebody, right? So thinking about possible triggers like those. Anything else? Let's see.
Well, if he thinks he's going to be hospitalized, since he was forced to be hospitalized in the past.
Yeah, that can be very triggering, right? I have seen actually a patient just bolt out of the clinic once somebody said that they might have had a really bad infection in his leg, and they were talking about possibly sending him to the hospital, and he just ran out of the clinic. So I think we have to be very careful. Okay, what were some of the strategies that you thought about?
With the forced hospitalization, to explain why he might need this treatment, but also emphasize the autonomy that he decide.
Yeah, I think sometimes having the explanation even before you even mention the possibility of needing and because it's so this, and because you need this type of care which we can't do in the clinic, this might be an option for you. What do you think about that? And always making it like he has control, right, over that, not you need to be hospitalized, right? Which oftentimes we say all the time to patients, you need to be hospitalized, right? Other strategies.
Reassuring him that he's safe here, that his daughter will remain with him as long as it's appropriate and safe for her. Unless we have to do an exam on him, but that will keep them together.
Yeah. So many parents, especially single parents, especially single dads that are houseless, have a real fear of their kids being taken away from them. And it's very real because you have people from the public calling CPS all the time when they see kids that are houseless, and they'll call CPS on that family. And it is not necessarily child endangerment to be houseless, right? I mean, I feel like some of the kids that live at the boat harbor, they get much more attention and better care than some kids that live in houses, right? And so, but people are making judgments all the time and feel understandably so. Of course, we don't want any child to be houseless, but that doesn't necessarily mean that they're being abused or neglected or but many of our patients have had to face that in the past. So definitely making sure they understand that that is not the intention of any of the questions. Right? You're not gonna. Our old JLC clinic used to be right next to the police station, and that was not a very fortunate location for us, and it did keep some of our patients away. So, other strategies for Jeremy. Strategies. I think a lot of times when you know that, especially with parents, and because he's expressed his concern about his daughter, you know, you can try to work goals around his feelings for his daughter, right? Like about that taking care of his hypertension and, you know, making sure he stays healthy is going to be the best thing for his daughter, right? Because then she'll have him around and she'll have him to take care of her. And that, you know, if he's sick, then, you know, there's more of a likelihood that she would have to go under somebody else's care. So, you know, not to say that you threaten him with that, but just kind of pointing out the benefits for his daughter of taking care of himself too. Okay, very good, thank you. Okay, last group here with Rosie. Somebody read Rosie. Okay, very good.
Rosie is a 74-year-old Marshallese woman. Rosie is Marshallese elder who came to Hawaii for health care with her family, but became houseless due to living support. She currently lives in Thomas Square and has congestive heart failure. She speaks limited English and prefers her native language. Rosie was displaced from her home island when she was very young due to U.S. military testing and nuclear fallout. She has endured chronic cultural marginalization and language barriers since moving to Hawaii 12 years ago. She has one son that moved to the continent and wants her to come live with him, but she fears being a burden for him. Her husband died 6 months ago from a sudden heart attack, and she has also lost multiple family members without children.
Okay. What other possible triggers?
We talked about talking about her health specifically related to her heart. We talked about that about she lost and as well as about the things that she lost.
And you know, she has heart failure, so you have to be very careful, right? Other triggers for her.
I don't know, just like family history in general, being sensitive to talking about that.
It is different for people that lose people suddenly and have not had any time to have kind of that closure with them, right? Other things that might be triggers.
We also kind of discussed maybe one of the barriers that she has for accessing care in the first place is probably because she feels like maybe she's a burden. Just the fact that she doesn't want to be a burden to her son. Access to health care. Oh, I don't want to bring.
Yeah. I think there's you know, that's definitely something that we encounter, and like if you're constantly like trying to encourage her to go live with her son, right? And you may feel like that would be the best thing for her, and like why does she choose to be houseless when she has an option to go live with her son, right? I think a lot of times people feel like that, and so they'll express those feelings, but that can actually make her more closed off because that's something she truly doesn't want to happen, right? So other things, anything else might be triggering for her?
We also talked about the fact that she speaks limited English, so if you speak too quickly or use really big medical jargon, then she could feel maybe reminded of instances where people made her feel dumb.
Yeah. Yeah. And a lot of times, you know, when people don't have English as their first language and you're speaking to them in English and they don't want to seem like they're dumb or that they are, not being adherent with what you're saying, they'll just agree with you. They'll just nod their head and they'll seem like they are understanding what you are saying to them, right? But that's why checking for understanding is really important, because you can't assume that they actually understand just because they're nodding along with you. I feel like sometimes you guys do that in class, right? You'll nod, you have no idea what they're talking about. That happens to me too, like at conferences. Yeah.
So in that sense, our group talks about offering a translator because she's more comfortable speaking her native language, but doing so in a gentle way, just to reassure her that it's not because she's dumb.
Yeah, exactly. The other thing we need to be careful about, and this is something that we actually learned through the process of our clinic, but so they always say that when you use an interpreter, that it shouldn't be like a family member, right? It shouldn't be a family member because they can't be objective, and maybe the family doesn't want like certain family members to know, and that they're not going to necessarily translate exactly what you're saying. They're going to interpret what you're saying and then say it to their family member, right? So there's a lot of reasons you're not supposed to use like friends or family members. But something that we learned in the Marshallese and Chuukese community here is that the community is so small, and like almost like not everyone, but like a lot of people know each other, right? Like they know families and things like that. And so the chances are that the interpreter is going to actually know them. And then it's worse for them, for a stranger, to then know what's going on with that family that might talk to other people in the community, even if they're not going to, right? That it's almost better if they would much prefer having like a family member or a trusted friend be the interpreter in that situation. And so I think like sometimes we have to break our own rules about what is best, right, for a patient. So yeah, I think that, but definitely offering interpretive services is important. Other strategies that you guys thought about?
We kind of talked about using silence as a tool. So if she doesn't want the translator and it seems like maybe she's stumbling, to try to get the words out, letting her get there on her own as opposed to doing this, doing that. It's really taking the pressure off and letting her have that space to navigate that problem.
Good, very nice. Other things?
Trying to her feeling of being a burden. We have like very briefly touched on it during medical communications, but just simply telling her we're not going to abandon her, that we're there for her, making sure that she knows that we want to help her and not that we are obligated.
Yeah, that's an excellent point. And I think that many times, not everyone obviously thinks they're a burden to others. Some people who should think they are don't. But it's usually the people that shouldn't think that way that do. But yeah, I think that that's really important, that they know they're not being a burden by being like a patient. And then a lot of times, maybe over time, that will translate to then her family, right? Like she will stop viewing herself as being a burden to her son. Any other strategies that you guys thought about? I think you guys talked about most of it. And then I think just, a lot of reassurance and, maybe being a little more like familial in terms of how you're speaking, not so formal, right, with how you're speaking. Oftentimes is very helpful. So, okay, very good.
As I listened to these, there's so much insight that I heard based on quite short descriptions of these different patients. And so firstly, from a trauma-informed perspective, like a lot of times we won't have the context, and yet all of the ideas that you brought forward would probably be helpful for most patients, or if something's not working the way you thought it might, then you could pivot and use one of the strategies you brought up, right? The other thing I was thinking was, with Dr. Kasuya, we've been talking about how do we write our HMPs, and soon we'll be talking about oral case presentations. These really short descriptions, I thought were given in a pretty neutral way that we could even say to the patient, like, can I put this into your chart? Is it okay if I included this context? Because then without having to retell that story, all the things you all came up with, others on the team could have that same opportunity to think, oh, maybe I can have better success with this patient by doing some of these things. So it can be extremely empowering. That's why we talk about our words really matter. And it's not just to tell a story and get the bigger picture, but so much of what you talked about is directly impacting then how are we going to offer treatment? How are we going to take care of this relationship? So, yeah, thank you.
Great. Okay, well, we are done for today. Any questions about either trauma-informed care or home project or crisis management? And of course, you can always email or contact us after. Okay, thank you so much, you guys.